Good morning, dignitaries. So, we start this beautiful Saturday morning with the beginning of the EMOCON 2026 session with the Adiposity Masterclass of this year, which will be chaired by Dr. Sushil Patel, who is a consultant diabetologist from Akshar Diabetes Center, Vadodara, and Dr. Prashant Shankar, who is a consultant in internal medicine and diabetes from MGM Muthoot Hospital. Over to you, sir.
So good morning, all of you, and thank you to the organizing team to giving us this opportunity. And to start the day one with the EMOCON 2026, we would like to start with the Adiposology Masterclass 2026. And to start, I want to invite Dr. Ekedas sir on the stage. Please join us, sir. He is a very well-known academician, professor, and teacher for many of us. And yes, sir, you can join over there.
Dear friends and my dear and esteemed chairpersons, I'm extremely happy to be here this morning. And we'll just start off by saying that this is a conference with a difference. If you look at the program, the theme runs through the entire gamut of metabolic medicine, of which obesity is one very important facet. I have got 10 minutes time and I'll introduce the subject and think about the second thing. So there are two presentations. Can I have the first one, please? It's about the adiposology. It's not coming there. Not coming on the screen.
Slides, please.
So what is adiposology? That is important to remember in the beginning of this particular program. Now, it's a dynamic endocrine organ. Dynamic endocrine organ. It is central to three things: obesity, inflammation, and metabolic disease. Further, you can say that it is central to obesity because of few factors I'll highlight. Inflammation, of course, and metabolic diseases, the IR and whatever you call it, lot of things. Now, why it matters, why this conference, Supratikda, to whom we owe a lot. I'd give a big round of applause for Supratikda, who has organized this unique conference. Why this matters? This matters, but it is the adiposology is the scientific and medical study of adipose tissue, with emphasis on its endocrine activity and its influence on the metabolic health and disease. No longer viewed as a passive fat store, it is a metabolically active organ that regulates energy balance, number one. Number two, inflammation, insulin sensitivity or insulin resistance, and glucose homeostasis. Now, this endocrine gland is beyond energy storage, and three things it has: adipokines, secreting the signaling molecule, it controls the energy balance and the inflammation. Now, there are various types of adipose tissue which we will discuss today in this meeting. I'm just giving the sensitizing first 3-4 minutes. We'll discuss the three types of adipose tissue we have: the white, the brown, and the beige fat. We'll also discuss this clinical school of adiposology. Dear friends, believe me, that is the core field of fat dysfunction, and its assessment and treatment very important. Number one, for the cardiometabolic disease and cardiometabolic risk, and also insulin resistance, the adipokine balance. Now, it contributes also to hypertension and dyslipidemia, and it extends to most important disease of the day, the muscle or the hepatic steatosis. Dear friends, it's also clinically important because it's a major public health concern. I was just told by my very good friend Breach that ADA has taken up in 4 countries to see the impact of the obesity, and India has been chosen one of them. And Bridge, we congratulate you to be taking it forward, Bridge, for the taking it forward on behalf of the ADA for India. Now, and you'll be having his own committee where everybody will be there. And that's why it's very clinically very important. Now, we have the management priorities. We have to think beyond the body weight. We'll discuss this. This is a sensitization. And therefore, adiposology recognizes adipose tissue as a central regulator of metabolic health. Effective care requires multidisciplinary management. Dear friends, I'll come to my topic allotted to me. And I don't know how Suprasida thought of beautiful topics, rethinking. Can I have the second? My friend, rethinking diabetes. So this is what I'll present for the next 7-8 minutes, or even less than that, 6 minutes. Dear friends, there has been a lot of advances. When you think of rethinking, it speaks about the way we look at it today. Yeah. You know, what is rethinking? A modern disease-oriented framework for understanding obesity, adiposopathy, and the long-term management. Next. Dear friend, why obesity needs rethinking? Why this topic? Obesity was often looked upon, reduced to only excess calorie intake and low physical activity. It is no more that. It has gone beyond, as you will see today, from this 9 o'clock till about 1:35. It is now understood as a complex, chronic, relapsing disease, which is multifactorial, involving adipose dysfunction, neurohormonal imbalance, and metabolic disturbance. The new concept of obesity centers around as a chronic medical condition, a chronic disease requiring long-term management, not merely saying that lifestyle. It's a sick fat. Adiposopathy, as my colleagues will present, is a sick fat with abdominal adipokine secretion, insulin resistance, and inflammation. Weight regain is common, so lifelong follow-up is necessary. I think JJ is going to speak about the set point. Beautiful speakers. I tell you, I'm in love with this particular meeting. BMI does not distinguish fat from the lean mass or the fat distribution. Therefore, today, we have various types of obesity, which we'll discuss in one of the talks. What is MHO, what is MONW, the metabolically healthy obesity, metabolically non-healthy obesity, metabolically obese but normal weight people. We'll discuss all about that. And the gut-brain homeostasis, which is absolutely fresh from the oven. You will find a lot of new things about gut-brain axis and how does it control the obesity. We have to think beyond BMI. Today, the limitation of BMI will be spoken to by my friend. I think the framework will continue that. We have useful additional parameters, which are many. I think Suprasida will highlight few of them, which are very useful to us. So today, we need a totally new framework. The problem with the old approach is focused mainly on the weight reduction. It overlooked the metabolic health and often blamed that you are eating more, you are not walking, you are eating more, walking much less. But today's direction towards this adiposopathy, adipose disease or obesity is a better framework with disease-oriented, rooted in the pathophysiology and designed for the long-term management rather than short-term weight loss alone. So the scope is beyond many things. The framework will be spoken to by Dr. Supratikda. I'll just give introduction saying that management framework involves anthropometric, clinical, metabolic, behavioral, and psychological evaluation. See the dimensions. Identify the high-risk individuals and guide treatment intensity, and lifestyle interventions, medical therapy, surgical therapy, continuous follow-up, relapse prevention. So this is a very huge gamut of things we're going to discuss today. And I'm very much concerned and delighted that it is today recognized as a very important metabolic risk which occurs early. And we have to promote education and healthy choices which can prevent it. And support healthy behavior early in life. Encourage various things like diet quality, physical activity, which will be discussed here. So this framework matters because we'll be addressing underlying mechanism, improving the sustainability of care, and targeting the diabetes and the CVD risk. That's very important. The cardiometabolic risk can be prevented. And it integrates metabolic and psychosocial health and matches modern obesity science. That's the beauty of this. Therefore, I close by saying one sentence that obesity today is managed as a chronic disease with heterogeneous phenotypes. We'll discuss all that. Very eminent speakers will speak about it. There are neurohormonal drivers and long-term relapse risk. That's called the set point theory of weight regain. Effective care requires, that is built in this conference, built in this masterclass also, it requires structured, individualized and multidisciplinary approach. Dear friends, I invite you for this great meeting, and let me just invite Supratigda,
Yes.
the person who conceived the idea. I will be speaking in inauguration, 3 years back, and how he has struggled and made metabolic medicine obesity in the center stage. We'll be speaking about the concept of adiposopathy and the framework, new framework. Dada, all is yours.
Thank you, Professor Das, for so nicely setting the context, and it's been my endeavor to get everybody together who has been working so sincerely in this field and have their heart in, metabolic medicine and, in terms of caring for people living with obesity in the first place. So it's an absolute pleasure to welcome all of you in Kolkata. We are having really nice showers in the evening, which is making the evening very pleasant. You might find the mornings to be a little hot, so stay inside. We have arrangements for you, and may I have the slides for me, please? So this adiposology concept came because I had been hearing about this term adiposopathy. So before you go to pathology, you have to establish physiology, and I think that's where it stems from. So we have just sent in the paper which got accepted, and me, Mr. Thambu, and Dr. Sabjisachi sent from Washington. So we are the three co-authors of this particular paper, which just recently got accepted, and will highlight what are important sort of takeaways from this. So it's a concept, as we said, and it's a tissue-centric lens for metabolic disease beyond BMI. And why this matters right now? Because with the same BMI, we know that people can have different metabolic risks. With normal BMI, people can have visceral and ectopic fat, which can be concerning. Same obesity can mean different metabolic risks. And in Indian context, this becomes very important because higher risk at lower BMI, as we know, central adiposity despite normal weight, and rising lean type diabetes and MSLD. So BMI measures size, it does not capture the adipose dysfunction. So that is the core concept. So the core problem or pathophysiological disconnect that we very commonly see is, this is the current clinical focus. We are organocentric now in approach, and we want to treat things upstream before the disease state develops. So that's our endeavor. So we want to address obesity because we know that eventually it's going to result in diabetes, metabolic disorders, blood pressure issues, and all of that. But we want to act upstream so as to prevent this disease condition and also the complications that arise out of this. So the BMI limitation in India is always felt, and if you look at BMI and the body weight only, then we are only reaching the tip of the iceberg. So the hidden part is the visceral adiposity, the ectopic fat or the spillover that goes to the liver and muscles, the insulin resistance, early metabolic dysfunction, and the Indian phenotype obviously are at risk, as we clearly established, and we know that we are very differently built. We are thin fat phenotype, and BMI reflects what is visible, not the underlying metabolic risk. So the new definition is obesity is not just excess body weight, but it represents the dysfunction of adipose tissue driven by impaired fat storage and abnormal signaling. And there's a shift in perspective. So we're going from a weight-based approach to a function-based approach. We're going from BMI to biology, and we're going from fat mass to how the fat behaves. So obesity is not a disease of weight, but adipose tissue dysfunction, as Professor Das clearly established. So what goes wrong? So you have normal adipose tissue and with adequate expandability, physiological lipid buffering, etc. And in the dysfunctional state, you have adipocyte hypertrophy, you have impaired expandability, and you have cellular stress and maladaptive remodeling. So you have endocrine and immune dysregulation where there are adipokine imbalance. You can have chronic low-grade inflammation. And then at the level of the adipose tissue, you have dysfunction, which means depot-specific fat distribution, adverse metabolic signaling, leading on to insulin resistance, and then lipid spills over, and elevated circulating free fatty acids, loss of adipose tissue containment, and then development of ectopic fat around liver, muscle, pancreas, kidney, and heart, and metabolic dysfunction continuum like diabetes, MSLD, cardiometabolic risk. So this is part of the, the paper that we submitted. It's a nice flow chart which we liked. And so these are the key drivers of adipose dysfunction: loss of safe fat storage capacity, dysregulated signaling and inflammation, and lipid spillover. So this is the continuum: adipose tissue dysfunction leading on to impaired storage capacity, and then impaired expandability, as we talked about, then endocrine and immune layer, resulting in adipokine dysregulation, chronic inflammation, and finally the disease state. So introducing adiposology is an integrative clinical framework that interprets obesity and metabolic disease through adipose tissue dysfunction. What it does, it takes you beyond BMI as a sole risk marker. It integrates adipose biology with clinical assessment, explains metabolic heterogeneity across similar BMI. So we're moving on from how much fat to how fat functions, and it's operationalized. Sorry, I didn't take my T. It's operationalized through 4 pillars of adipose dysfunction: A, distribution, expandability and fibrosis, immune and endocrine signaling, and ectopic lipid overflow. So what we're trying to say is that it's not a new disease or specialty. So it's just a framework, and it's a clinically oriented framework for understanding of metabolic risk. So the 4 pillars of adiposology are, pillar 1 is distribution, visceral versus subcutaneous fat; expandability, capacity, fibrosis; immune 3 is endocrine, like adipokines and inflammation that is ongoing; and then finally, the 4th pillar would be the ectopic fat that is around the, the organs. So going to the first pillar, fat distribution, increase in visceral adipose tissue, leading on to increased lipolysis, inflammation, insulin resistance. And we know that subcutaneous adipose tissue is protective, but when it is in excess and it's dysfunctional, it goes around the organs, and also the central adiposity, even at normal BMI. So why BMI alone fails? Because if you consider a patient who is metabolically obese, normal BMI, we know that the waist size or the waist hip ratio has to be taken into consideration because it's very uniform throughout all ethnicities, and then the TG-HDL ratio could be high, and if the HbA1c is borderline, that means it's a lean type 2 diabetes phenotype and is at high risk for developing disease conditions. If you take patient 2 who is metabolically healthy obese, again, one term that we are trying to come off from, because even if the person is metabolically healthy now, he might develop a disease state later on. So we need not sit on it. And then the patient 3 is the high-risk obesity subtype with visceral and ectopic fat, where the BMI is high, the waist size is high. You clearly have high labs like increased ALT and HbA1c, and they're at very high risk of visceral and ectopic fat, and hence a disease state. So metabolic risk is determined by adipose distribution and function, and not just BMI. And pillar 2 is adipose expandability. Again, hyperplasia and then hypertrophy, both of them come into play. And the core concept, adipose storage capacity, determines the metabolic risk. Limited expandability, like hypertrophy and fibrosis, restrict safe storage. Buffering failure is there, so lipids spill over into liver and skeletal muscle. and risk of modest BMI, early fatty changes. And when fat cannot be stored safely, it is stored somewhere else, and that is the concern. So immune endocrine signaling, so usually the body is built in such a way there's a balanced signaling, and if there is a dysregulation, obviously that results in a disease state, starting from insulin resistance, and that leads on to an inflammatory state or meta-inflammation that results in further chronic inflammation and the metabolic conditions that we were talking about. So ectopic lipid overflow is also there. So there's a spillover and going to the organs, and that, in a sense, when fat is stored in the wrong organs, metabolic diseases begin. So what are the things that we can simplify and take into consideration? One is the waist to height ratio. As we said, it's very uniform throughout all ethnicities. We can look at the insulin resistance by doing a TG-HDL cholesterol ratio, hepatic fat content by doing the biochemistry like ALT, or we can look at the FIB-4 score, and then glycemic stress doing HbA1c, and then metabolic surrogate like a HOMA-IR or TG-HDL ratio. So use routine clinical markers to phenotype metabolic risk beyond BMI, and screen for high-risk individuals. So screen for everybody that is coming. In fact, if it is an Indian, and we know that they are all having abdominal obesity, and we need to be very proactive in terms of screening, and the screening parameters are mentioned here. And then phenotype-wise, distribution, expandability, immune endocrine issues, ectopic fat, and prioritize target dominant adipose dysfunction, reduce visceral and ectopic fat burden, improve insulin sensitivity, and reduce cardiometabolic risk. So routine OPD tools are sufficient. Why adiposology approach matters in Indians? Because of the adipose distribution, phenotype risk, metabolic consequences that develop, tissue level detection, and Indian patients' adipose dysfunction, not BMI, drives the cardiometabolic risk. So simplified diagnostic, routine application, and proactive care is very important. What changes in clinical practice? So the history changes. Instead of BMI-centric approach that we used to do, now adiposology-based approach will have phenotype-based assessment, tissue-centric risk evaluation, early and precise risk detection, and mechanism-aligned clinical care. So bottom line, BMI-based care is moving on to phenotype-based metabolic management. So the take-home messages, I'll leave you with that. Oops. How do I go there? Can you go to the last slide for me, please? Yeah. So obesity is often adipose tissue dysfunction, not just excess weight. This is the first take-home. Adiposology provides a tissue-centric clinical lens beyond BMI and enables mechanism-based phenotype-driven risk assessment. So in an era where we're talking about precision medicine, we have to come off from the gross assessment and then customize and individualize an approach and start looking beyond BMI for your next patient. Thank you.
Thank you, Supratik, for that wonderful session. And as you can see from the topics, it has been wonderfully crafted. We started from by setting the tone and then establishing the concept and framework. Next, we would go into the core adipose tissue physiology and endocrine and metabolic functions of adipose tissue. For this, I would like to invite Dr. Brij Mohan. Sir, please take over the podium.
Just get your questions ready. We'll be having 10 minutes for discussion after every third talk. Please get your questions ready. We can have a good interaction.
Thank you, Supratik, for the opportunity. And thank you all for coming so early in this beautiful venue. I came here for the first time, but this is too beautiful. We know that adipose tissue are different. than what we used to think. And that is why Dr. A.K. Das, Professor A.K. Das told us certain things which are beyond obesity. It is more of insulin resistance. It is more of cardio-renal involvement in adipose tissue. So with that thing in mind, we dwell into adipose tissue. Do we have slides ready? Sorry for the technical glitch. No, this is, see, okay. The name is longish. Adipose tissue physiology, endocrine and metabolic functions of adipose tissue. But I will not chartify you. We know that adipose tissue are different from what we used to think in what it is exactly right now. This is composed of subcutaneous adipose tissue and visceral adipose tissue. Visceral adipose tissue are basically abdominal visceral adipose tissue that includes fatty liver and pancreas. We know that fatty liver is not being emphasized these days. There is epicardial adipose tissue and there is perivascular adipose tissue, which is very, very important from cardiac point of view. So traditional view was that adipose tissue is energy store. That is what we used to read. But the modern view is that they secrete hormones, they secrete cytokines, they secrete bioactive factors. Adipocytes have two tail tissue, visceral and subcutaneous adipose tissue. Visceral adipose tissue, basically abdominal visceral adipose tissue, may be omental, mesenteric or retroperitoneal. They are highly metabolically active. That is why they say that NAFLD or MASLD is the new dictum to look for. They are constantly releasing free fatty acid. They contribute to metabolic syndrome. Subcutaneous adipose tissue are 80% of, they are basically metabolic sink of excess adipose tissue. They are insulator, they are barrier against dermal infection, and they prevent development of cardiometabolic syndrome. So with that in mind, we need to reconsider, rethink about adipose tissue from energy storage to endocrine organ. This slide tells you about immature and mature adipocytes. Mature adipocytes can be white, brown, or beige. Beige is in between brown and white. This is what exactly they look like, and now the endocrine factors released by adipose tissue. We know that white adipose tissue is there. They are basically regulated by inactivity, caloric excess, and thermoneutrality. And there is brown adipose tissue, which is protective, which is good adipose tissue. They are produced by exercise. Very, very important. The mitochondrial content of adipocytes increases by exercise, cold exposure, and caloric restriction. We need to eat lesser and lesser. There are certain factors being released by white adipocytes. They are pro-inflammatory tissue, resident immune cells. There are certain factors released by brown adipose tissue. They are anti-inflammatory tissue and resident immature cells. Adipocytes, there is network of endocrine signals. Number of them are there. Maybe more than 600, but important are what we recognize at this point of time are 30, more than 30. They regulate glucose metabolism, lipid, energy homeostasis, pro-inflammatory and anti-inflammatory responses, and they add to adapting to the metabolic challenges like starvation, like stress, like infection, the period of energy excess that is there with adipocytes. Obesity, increased visceral adiposity leads to insulin resistance. Here is the timeline of obesity. There is increased adipose tissue. There is increased production of pro-inflammatory cytokines, maybe fatty acids. There is leaking of lipids to other tissue. They interfere with insulin signaling, and they help in development of insulin resistance. This is what it looks like. Visceral fat leads to inflammation, that leads to metabolic syndrome. How visceral fat leads to inflammation? There is excess nutrition which is there chronically, enough with not enough protective response. Exercise is lacking and the nutrients are high. There is adaptive inflammation by adipocytes that leads to release of pro-inflammatory adipokines. There is release of inflammatory markers. There is fibrosis. There is rapid aging of cells. There is positive outcome and there is negative outcome. Adipocytes, endocrine effect on various organs. Here is the systemic representation of how the organs are affected by adipocytes. They are affected by the brain, pancreas, cardiovascular system, liver, very important. Musculature is very, very important these days. Adipokines cause insulin resistance. How it happens? Adipokines, these are the adipokines responsible for various adipokine activity. They affect muscles. There is impaired glucose disposal. They affect central nervous system or the brain. There is effect is obesity, and they affect liver, that is leading to reduced suppression of glucose production. Different fat depots in metabolic health. These are subcutaneous fats, visceral fats, epicardial fat, very important in cardiovascular disease, pericardial fat, perivascular fat. Take home message is subcutaneous fat is protective, visceral and ectopic fat is harmful, brown and beach fat is beneficial. So what is the bottom line? The distribution matters more than total fat mass. That is what is there in modern adiposology. Adiposopathy leading to cardiovascular disease. There is positive caloric balance, unhealthy nutrition, sedentary lifestyle that along with genetic predisposition and environmental predisposition, there is hepatoadipocytes hypertrophy and visceral adiposity, and these are the effects, and there may be direct effect on CKM involvement, maybe indirect effect, that is atherosclerosis. What is the clinical use of learning all this? Adipose tissue as endocrine organ, what can a physician do? 5 steps I tell you. Step 1 is assess BMI, although it is not the correct indicator of adiposopathy. Waist circumference, blood pressure, metabolic syndrome features are to be assessed. Check lipids. Step 2 is check lipids, liver enzymes, kidney function, maybe if the time permits, inflammatory markers, or if the pocket permits. Imaging of step 3 is imaging of liver fat. 5th 4 score, where possible, visceral and epicardial fat. Stratify patient into low risk, intermediate risk, and high risk. That is what every clinician should do in day-to-day practice. And step 5 is intensify lifestyle changes, maybe pharmacotherapy depending upon risk profile. So the take-home message is adipose tissue is active endocrine organ that releases multiple hormones, regulates glucose metabolism, lipid metabolism, inflammation and energy balance. In obesity, adiponectin decreases, reduced insulin sensitivity is there, leptin increases, that reflects total fat mass but often causing leptin resistance. These hormones, they influence the insulin secretion, gluconeogenesis, inflammation and glucose tolerance. These adipose-derived signals can be protective in lean state, but shift to pro-inflammatory and insulin-resistant profiles in obesity and drive various cardiometabolic diseases. With that, thank you, sir, for giving this opportunity.
It's a wonderful talk on the physiology of adipose tissue. And now let's shift from the physiology of adipose tissue to the physiology behind the hunger and the satiety. So I'm inviting Dr. Vinod Mittal sir from the Delhi. He's talking on the hunger to satiety, the role of gut-brain adipose axis. Over to you, sir.
Very good morning, everyone. And it's my proud privilege to be here to share my knowledge on gut adipose brain axis. And I convey my thanks to my dear friend Dr. Supratik and the entire AMOCON team for inviting me. So from hunger to satiety, how this cycle goes on and how this becomes dysfunctional and how we get, diabesity. So there is a role of, we were discussing previously gut and brain axis. It is mainly gut adipose brain axis. So overall, like in brain, hypothalamus is the control center for everything. It has control on homeostatic energy and metabolism. So in a normal person, there is a control, there is a homeostasis between energy intake, expenditure, and metabolism, so that, a normal weight is maintained. Now, gut, basically, there is, when we, are feeling hungry, there is release of ghrelin, and which leads to hunger, and followed by release of CCK, GLP-1, and PYY to, get satiation and satiety. In adipose tissue, there is a clear-cut role of leptin, when we, it's again a control center, control hormone for our satiety. Okay, so that's how this cycle goes on. Dysregulation of this axis makes you to have metabolic syndrome in the form of obesity, diabetes, and gut dysbiosis. We've been talking a lot on this. Leads to unhealthy, leaky gut and inflammation and diabetes. Then like insulin, initially there is a phase when there's insulin resistance, insulin and ultimately hyperinsulinemia and relative insulin deficiency. Similarly, leptin is a good hormone to have control on satiety, but later on there is a hyperleptinemia and leptin resistance when you have a full-fledged obesity, and then endotoxemia. So this is, easier to understand, like hypothalamus is the main control center. It gets input from, basically directly from the, nutrients, the food we consume, efferent vagal nerve, and then spinal efferents. Going to nucleus tractus solitarius and going on to the arcuate nucleus. Arcuate nucleus is the main center in hypothalamus for control of, hunger and satiety, where most of the medications act. So this will make things more, easy that basically this is arcuate nucleus, and these are neurons basically, NPY, AGRP for their oxidogenic means stimulation of hunger, and POMC that is pro-opiomelanocortin and basically, cocaine, amphetamine regulated transcription factors. So this is, one hand there's a, for hunger stimulation, and this is for control of hunger, satiety, okay? So orexogenic and aneroxogenic neurons. Now, most of the anti-obesity medications, they act on POMC. You must be knowing this, and the control of satiety. That's how it is acting. So basically, gut-brain communication is through vagus nerve as efferent, and then nucleus tractor solitarius, which is present in the hindbrain, and from there it goes to arcuate nucleus. And that's how, this cycle goes on. So hunger signals are, they start with basically ghrelin and a vagus nerve. Satiety is release of cholecystokinin and PYY and GLP-1 from the gut, and leptin later on to achieve proper satiety. So pre-meal, there is a sight and smell of food which activates the cephalic phase. And during the meal, when the food is digested, there is gastric stretching, which leads to release of GLP-1, PYY, and the protein component. This is another important thing which I want to highlight, that during the meal, if you take protein first, followed by carbohydrates, that will decrease the glycemic index of the total food. So instead of having carbs first, followed by protein in the same meal, you have proteins first, followed by carb. That will, make things much better. So proteins are also, they have a low glycemic index, and they, make you feel full early. And post-meal, what happens? Leptin comes into play and gut microbiome. So this is the satiety cascade model. We can see the meal quality, that is, the flavor of the meal, texture, nutrient composition, followed by, meal quantity. When you eat, there's a gastric stretching leading to a satiation, and then ultimately, a leptin and gut microbiome come into play. That's how this goes on. So in short term, for short-term control of satiety after hunger, it is CCK, we can see here, PYY. Ghrelin is to get hunger. After that, control of, to achieve satiety, there's release of CCK, PYY, and GLP-1. And on a long-term basis, like when food is consumed, it goes to circulation, it goes in the, adipose tissue as healthy food. I'm talking of normal people. Then leptin and insulin are the hormones which regulate that. The normal deposition of normal fat because in a normal body. But if there's a dysfunction, it becomes abnormal, okay? Now, this is another important thing, is the hunger is of two types, homeostatic and hedonic. Now, homeostatic is normal. Everybody will have hunger, but we stop at a particular time and we have a normal life. Hedonic is eating for pleasure, which most of the people, are now, into it. And this involves dopamine, and it is a kind of a reward system. More tasty food, unhealthy. And the irony of life is, unhealthy foods are more tasty. Healthy foods are less tasty. So this hedonic phase is the killer, basically. You eat more, you feel hunger, and then you eat more. Okay, so you have to control. The point why I'm saying this, GLP-1 agonists, they control this hedonic stimulation. Okay, so that's an important thing. That is why with your self-control along with GLP-1, that makes things better. There are many other, factors for hunger, like it is only a small thing, like, food preferences, then socio-culture factors, environment plays a role. So those are, different psychosocial factors. Now, gut-brain axis. So I'll take, gut-brain as separate. Now, gut-brain again is three things there are. Now, one is brain, other is a gut, and then gut microbiome. Gut microbiome are the second genome of the body. There's so much research going on that the future is now gut microbiome for treatment of various diseases. So we can see here that high-fat diet leads to inflammation, and then, like red meat also leading to a different bacteria which are harmful. High-fiber diet, on the other hand, is anti-inflammatory and anti-anxiety. So biome banks are there in the world now, and it's a 100 million, more than that industry. And biome is a second genome. No, we always talk of genome, genotyping, but biome is second genome. And once we have this, and in times to come, again there would be like zonulin, fecal, caloprotectin. These would be the markers for cardiovascular risk. In stool, you do these markers, you would come to know that this person has this risk. So this is the future again. So bottom up, top down approach. We say my gut feeling, gut controlling the brain. And this is true. We feel brain controls everything. No, gut controls the brain. So it depends on what we eat and how much we eat. And so it is basically a bottom up, top down approach. If we control our gut, we would be normal. Simple. Brain won't be able to do anything. So application in future would be strain specific. We have specific antibiotics today. Gram negative, we give aminoglycosides. Positive, we have this one. So in future, gut microbiome also would be very strain specific, means this gut microbiome for depression, this one for MASLD, this one for diabetes, for depending on different strains in that particular microbiome. So leptin resistance, as I mentioned, like insulin resistance, we have to give. Then insulin from outside, there's hyperinsulinemia. So leptin receptor agonists are in research, and they would be the future. Fluvoxamine, which is in SSRI, is again, acting on leptin, and flurbiprofen. These are under research. So there are many, aspects of this hunger satiety cycle. These are all conventional anti-obesity medications acting on POMC. We all know that. GLP-1 are for last now almost couple of years we have been using. So molecules of the past decade was SGLT2, and the future decade or maybe more would be GLP-1. Now, other interesting thing is when GLP-1 is released from the ileum, only 25% of this reaches portal circulation. Rest everything, metabolized very fast. We all know that. Within a minute it gets metabolized. So one is a small direct effect of this. 25% goes to portal circulation, and through vagus, hepatic vagal nerve, it goes to the brain, and only 10% reaches the systemic circulation, which goes directly to act on arcuate nucleus. That's how, so only very small and that is why DPP-4 came into play, and now we're giving GLP-1 in a super therapeutic form. This is evolution of GLP-1. Now, we have moved from single, dual, now triple. It was basically, we introduced, like introduction of GLP-1 was for control of glycemia. Weight was secondary. Now weight is becoming primary, and there is a role of dual now. So GIP with GLP-1 is more for obesity and control of glycemia, and then triple. So we are moving from glucocentric to adipocentric approach to have a better control. Now there would be some new future molecules, CagriSema, servodutide. Only one I would like to mention here is meritide, which is going to be the future once it is marketed. It is going to be once a month, or maybe more than once a month, once in 2 months, because we're giving now once a week. So if we have once a month, I think there's nothing like it. So basically now last but one slide, adipose brain axis is the main axis which controls our hunger and satiety. Hunger is homeostatic, which is normal, and I think we should control there. Hedonic is harmful, which is for pleasure, for tastier foods. And irony is that we have unhealthy foods which are more tasty, and they are more easily and affordable also. So unhealthy foods are easily available, accessible, affordable, and more tasty. Okay, so that comes, we have to. And other is that protein in a meal, take proteins first, followed by carbohydrates, will make lesser glycemic index of the total meal. So there is an interplay between brain, gut, which is through ghrelin and CCK, GLP-1, PY, and adipose tissue through leptin and insulin. So with this, I conclude my talk and I convey my thanks to everyone.
Thank you, Vinod, for a very, very lucid and very informative talk. Dear friends, as we promised, we have few minutes left, so we'll have a brief discussion and within time. So the topics are open for discussion. Maybe we start from the Professor Vinod Metal, then we'll take up Dr. We'll go Briz Mohan and we'll go like that. So any questions you want to ask Dr. Vinod Metal? Before Vinod answer the question, I'll give you one information. I don't know good or bad. A Indian Got Microbiota Society has been formed. And it is a free society today. I don't know, they will charge money afterwards. This society believes that gut microbiota, as you rightly showed, play one important role in the obesity pathogenesis. Now they have given 3 simple things which I'll read out to you, which I like. They say that your gut microbiota decides how much energy we will absorb, because they are the organs, am I correct, Vinod? They absorb the energy from the food, gut microbiota. So they decide how much energy we absorb. And then they also decide how hungry we feel, whether, as you said, gut-brain axis. And also, and how our body stores fat. Therefore, the Afrin Society has been formed. And last week in Delhi, a meeting was called by no other person than Dr. Ganguly. You know Dr. Ganguly? Ganguly is the previous ICMR DG, one of my teachers in Chandigarh. And the meeting was entirely on the probiotics. So, Vinod, my question to you, do you think that the probiotics will enter new arena of gut microbiota obesity axis management?
So I mentioned, they're already there. And the future is like GLP-1 would be gut microbiota. And like Akkermansia, the trials have shown that if you feed, like they have done this in fish. So they have fed, that fish rich in Akkermansia, and they found there was more production of omega-3 fatty acids. So what I want to say, that if Akkermansia is producing more, omega-3 there, it'll have the same effect in the humans, maybe. So ultimately, like we have specific antibiotics today for gram-negative, positive, and methicillin-resistant MRA. Similarly, we would be having strain-specific probiotics, and microbiota is going to
I think
play.
it's absolutely correct.
And sir, one small thing I would just say, that when a child takes birth, the gut is sterile. There's no microbiota. And till 1 year, it is the best healthy microbiota, till 1 year, if everything goes fine. After 1 year of age, now it depends on the parents and the kid and what we feed this child.
Important.
And that creates problem for the future.
I see, absolutely correct. Therefore, one of the slogans to prevent obesity to the newborn child till 1 year of age, don't give sugar, don't give salt.
Yes.
You're absolutely correct. Which
Yeah.
point? Yes, Dr. Briz Mohan. Tell us.
Many of the drugs we use these days, currently in use for many years, they probably affect gut. And one of them, the age-old metformin, acarbose, is one of the drug which affects gut microbiome.
Absolutely correct. And I'm a strong believer in the probiotics like curd. In South India, you take whatever amount of fluid therapy, what do I mean, fluid therapy. At the end of your dinner, you take curd rice. It says it washes off your sins of the fluid therapy. What does it mean is that it is a good source of providing the probiotics for the gut microbiota. Any question from the audience?
Sir,
please?
even GLP-1 also play a role
See, Vinod stays in Delhi and is Delhi Long Heart Hospital chief. I stay in a small place, so GLP-1 versus probiotics. Probiotics is cheaper and better. Any question? Please ask one question. We have 1 minute left, 1 or 2 minutes left. And my chairpersons have to give their comments. Yes? Ask anything upon earth. We'll try to answer. The new science
or we will ask.
Sir, one point I would like to add here,
Yes.
which the science has shown, that depression, anxiety disorders, there is also a role of gut microbiota.
Yes, sir. I think correct.
Previously, the conventional treatment used to be just some small counseling and mainly medications. Now, today, it is becoming that gut microbiota are playing more role, and there is reduction in the requirement. Even autism, some studies have shown that gut microbiota are playing an important.
Thank you. And if there are no more questions, I'll ask one line comment from my
जो जो दवाइयाँ गर्म करती हैं, जो खाना गर्म करता, probably it affects brain. जो ठंडा करता है, probably it affects gut microbiota and indirectly maybe brain.
Correct. So I like comment, one line comment from
Thank you, sir. Thank you for this wonderful session, and I congratulate Dr. Srupatik and the team to bring this master class. It is a eye-opener for all of us also that it is now time to move beyond the BMI and the waist circumferences. And again, what you had rightly mentioned, that the story should start from the birth, what we feed our child. It impacts the gut microbiota, it impacts the adipose tissue and adipology, adiposology and the adiposopathy also. Thank you, sir. Thank you for this wonderful master class.
Yes, just I want to add something more to that gut microbiota. I think the fecal microbiota transplantation is something which is coming up in a big way. It is already established for the management of ulcerative colitis and for hepatic encephalopathy. There are a lot of studies which are coming up in metabolic disease also. So
It's already done in some centers,
Yes.
FMT, fecal
Yeah.
matter transplantation, we call it.
yeah,
So in Delhi, in one of the ILBS, so it's already been, from stool samples are taken from normal people, and especially cirrhosis of liver and hepatic failure.
yeah.
It's already being done.
Yes, I think that is something which we will have to look forward for the future. And coming to this gut-brain axis, I think the biggest challenge which we face is spreading this concept to the common man. How to explain this to the common man, and they should have that idea that obesity is not just about eating and exercising, and there are a lot of things which play. So our responsibility will be to educate the common man that it's not just eating and exercising, but there are a lot of hormones which are there in the game, and these should be tackled for proper management of obesity. Thank you.
Thank you for the all.
Thank you, sir. Thank you.
We will.
सर एक फोटो आपके साथ में हो जाए.
सर एक नहीं सारे फोटो लेंगे. बैठिए सर, अभी तो खेल बाकी है सर. बैठिए सर, प्लीज. विल टेक फोटोग्राफ्स विथ प्लेजर. वी आर गोइंग अवे. नो, आर यू गोइंग अवे ब्रिज? हाँ, आई विल कम. सो या.
Thank you, sir, for the wonderful session. So, diving deeper into the into adiposology masterclass, we would go into insulin resistance and its Indian perspective. I would like to hand over the session to Dr. Swaraj Wadankari, who is currently the professor at Department of Medicine, MR Medical College, Kalaburgi, and Dr. Dhruvi, who is probably not yet here. Over to you, sir.
So let me now first invite the first talk is by Ritesh. Is the first talk by yours in this session? So dear friend, no, next. This is not there. So Ritesh is the director consultant at the Santi Pavan Multi Hospital, Bhubaneswar, also in the Apollo, and he has a lot of awards, and secretary of the Orissa Endocrine Society, and he's going to talk to us in a very important subject, adipokines. And please start.
Yeah, thank you, sir. And I must congratulate and thanks Supratik sir and the entire organizing team to take the pain to host such a nice conference on metabolic and obesity. From today morning, stage is nicely staged by the Das sir and Supratik sir. I will be discussing about the pillar 3 of the adiposology, where the adipokines and the inflammatory markers which play a major role in controlling the obesity and metabolic health. Previously nicely said, initially adipocytes are mostly meant for the storage house of the body, but with the excess hypertrophy or excess intake of food, there is hypertrophy of the adipocyte, which is responsible for the chronic inflammatory condition leading to metabolic dysfunction. So what the adipocyte, adipokines and meta-inflammatory marker tell us about the metabolic dysfunction? So these adipokines and inflammatory markers are mostly linked with the obesity, type 2 diabetes, cardiovascular risk and MASLD, what we are discussing for the last 2 to 5 years. So these adipocytes are no longer a passive organ of storage. Now they are secreting more hormones, cytokines and immune mediator which are responsible for the vascular and immune response. So in obesity, there is a dysfunctional adipocyte tissue which is a major cause of this systemic inflammation. Nicely, Binod sir and Makkar sir already said about the visceral and subcutaneous adipose tissue, where the visceral adipose tissues are there in the visceral part, but other subcutaneous and perivascular adipocytes are also responsible for the different disorder. What is meta-inflammation? It refers to a chronic low-grade inflammatory state induced by the metabolic excess rather than the infection or injury, and it is not the acute inflammation, it is the chronic inflammation which leads to the different metabolic condition. So if you see the pathophysiology, there is a excess nutrient intake cause adipocyte hypertrophy. Initially, because of the scarcity of food, God has made adipocyte to store the food, but nowadays with the availability, there is hypertrophy and cellular stress which lead to the signal activation of the NF-kappa beta, GNK pathway and inflammasome pathway. So if you see, starting from obesity, there is pro-inflammatory mediators which leads to activation of the signaling pathway, which leads to the adipocyte hypertrophy and metabolic dysfunction. And the process is completely cyclical, where one will leads to other and leads to the metabolic dysfunction. So the adipocyte, it not only contains the adipocyte itself, but it also constitutes the fibroblast cell, mesangial cell, macrophage and the vascular pathway. And this macrophage is responsible. So the macrophage, due to the overstress, either it can convert to the macrophage 1 or macrophage 2. So if there is a hypertrophy of the adipocyte, the most of the macrophage will convert to macrophage 1, which is responsible for the inflammatory markers production and the inflammatory cytokines production. But if the macrophage will convert to macrophage 2, either by the drugs or by the lifestyle change or by the exercise, this macrophage 2 will decide the adipocyte to produce the inflammatory or pro-inflammatory cytokines. So indirectly to gist, macrophage 2 is the good macrophage and macrophage 1 is the bad macrophage for the adipocyte to leads to the metabolic syndrome. And here you see, in a normal person, macrophage 2 is predominant. Once the metabolic dysfunction or mild metabolic dysfunction, the macrophage 1 predominating, and once the patient is obese with full metabolic dysfunction, macrophage 1 predominates over macrophage 2 along with the adipocyte hypertrophy produce different pro-inflammatory cytokines or adipokines responsible for the chronic maintenance of the inflammation, leads to insulin resistance, dyslipidemia and cardiovascular dysfunction. So how to classify these adipokines? As I have said, pro-inflammatory, which is leptin and resistance and others, and the anti-inflammatory, which is good adipokines, are the adiponectin, omentin and others. And they act as a hormone cytokines growth factor, bridging between the metabolic function and chronic inflammatory state like obesity, diabetes and dyslipidemia. So how these adipokines act? It both pro-inflammatory and anti-inflammatory. They act at the liver, skeletal muscle, pancreas, and adipocyte itself. So the pro-inflammatory cytokines like your lower one, that is beta oxidation lipolysis, they at the liver hepatic level, the adiponectin, which is the good adipokines like anti-inflammatory, they cause gluconeogenesis, steatosis, and decrease inflammation and fibrosis by the AMPK pathway, and the PPAR gamma pathway. They helps to increase beta oxidation, increase glucose uptake, and increase insulin sensitivity at the hepatic level. So this is the anti-inflammatory cytokines action. At the skeletal muscle also they have good action, and the pancreatic, they improves insulin secretion by the AMPK pathway. But the pro-inflammatory cytokines like the leptin, bisphatin, resistin, they have the opposite action as the anti-inflammatory cytokines. So as I have said, the adiponectin, which is the good cytokines, act by the AMPK pathway and PPAR alpha pathway to prevent the anti-atherogenic property of the molecule, and their level are reduced in obesity, diabetes, and cardiovascular disease. So you can measure adiponectin level to say your patient is metabolically active or inactive or dysregulated. Leptin, which is the pro-inflammatory, means the bad adiponectin or bad adipokines, I have to say, their level increases with the obesity and type 2 diabetes, and you can also measure leptin as a marker of bad metabolic cytokines, and it stimulates the TNF alpha, interleukin 6, interleukin 12, and also activate the macrophage towards the macrophage 1 and the different adipokine secretion to regulate the inflammatory markers. Resistin and bisphatin are also the pro-inflammatory adipokines, which in human it is primarily secreted by the macrophage, not by the adipocytes, and promotes insulin resistance. Bisphatin, which is again a chronic inflammation and has been associated with beta cell dysfunction, atherosclerosis, and metabolic syndrome progression. So these are the different markers secreted by the adipocytes, macrophage, and all the endocrine organ of the adipocytes causing the metabolic dysfunction. What are the emerging adipokines you have to see? The omentin 1, which is a good adipokines, improves insulin sensitivity and exerts the anti-inflammatory effect. Camerin links adipose tissue inflammation to vascular dysfunction, and fibroblast growth factor 21, which act as an adaptive metabolic hormone under the energy stress. So these are the emerging adipokines which may in future you able to measure it to define your patient who are good metabolic health or who are bad metabolic health. So the classical inflammatory marker TNF alpha, interleukin 6, HSCRP we all know, which are elevated in obesity, and this marker are good correlation with the insulin resistance and endothelial dysfunction, which is the major pathophysiological cause behind the micro and macrovascular complication arises in type 2 diabetes. NLRP3 inflammasome is the newer way to see the inflammatory marker in the adipocytes and adipokines kinetics, which is mostly a cytosolic multiprotein signaling complex that serve as a key component in this innate immune system of our body. And it not only comprises the one molecule, it comprises most of the lipopolysaccharide caspase 1 and caspase 1 dependent release of the interleukin 1 beta and 1-8 and proteolysis. But if you say specific dysfunction associated with specific adipokines like obesity specific adipokines profile, where leptin, adiponectin are the major, followed by resistin, bisphatin, and PAI, which is the plasminogen activator inhibitor, which raise in obesity and increase thrombotic and cardiovascular risk. So these are the obesity specific adipokines you measure for your patient to say they are good or bad. Adipokines mostly related to insulin resistance, adiponectin, leptin, and resistin we have discussed, but TNF alpha and others like retinol binding protein, bisphatin, and camerin are mostly associated with insulin resistance. So some of the adipokines are responsible for obesity, some are specific for type 2 diabetes and insulin resistance, some are specific for cardiovascular risk, some are specific for dyslipidemia. So by seeing the different adipokines and inflammatory marker levels, in future you can predict, or it helps also to give a prognostic marker of the different treatment for the prevention of metabolic disorder. Mechanism in cardiovascular disease, as I have said, dysfunction primarily driven by the visceral fat which is there, leads to atherosclerosis, endothelial dysfunction, hypertension and insulin resistance. And the adipokines which is responsible for the MAFLD or NAFLD, now the term is not used, but the major adipokines are the leptin responsible for the MAFLD. So the clinical biomarker potential like leptin, adiponectin and resistin are potent signaling driver for adipose tissue, and they provide diagnostic, prognostic and therapeutic tracking. What I want to say, these are the older marker and some disease specific newer adipokines which help you to diagnose your case earlier, treatment prognostication and tracking your patient in response to therapy what you are planning for your patient for the anti-obesity, diabetes and cardiovascular risk reduction. So what are the major intervention are available for adipokines? Adiponectin improvement is there with the diet and exercise. So the level of anti-inflammatory adiposokines are the adiponectin. There is reduction of leptin with lifestyle change. Impact of the diet like high fiber, whole grains, low in processed food optimize the hormone level. Exercise again, especially regular physical activity improves the adiponectin level, and weight loss helps to improve the beneficial adipokines level and reduce the pro-inflammatory cytokines. So these are the different adipokines: leptin, resistin, adiponectin, TNF-alpha, interleukin 16 and interleukin 18, their source from where they are produced and their function in the body and how you measure. Pharmacological approach, we all are discussing in the next 2 days about the GLP-1 analog agonist, which are the mostly reduce the visceral fat tissue, significantly improves the anti-inflammatory cytokines and improves the insulin sensitivity. We all know about the thiazolidinediones are a better PPAR gamma activity and enhancing the anti-inflammatory cytokines and decrease the pro-inflammatory cytokines. Metformin, which act by the AMPK pathway, how the adiponectin acts, mostly the PPAR alpha and AMPK pathway. Metformin also act by the same pathway to reduce the pro-inflammatory cytokines and improve the anti-inflammatory cytokines pathway. Emerging therapeutic target for these adipokines like the adiponectin receptor agonist aim to stimulate the anti-inflammatory effect, fibroblast growth factor 21 analog and the interleukin 1 beta antagonist anakinra to block the inflammatory signals in obesity induced diabetes are in the recent advances. We may get these molecules as anti-obesity and prevention of diabetes in future. Bariatric surgery and adipokines, the key changes included significant decrease in the pro-inflammatory factor and improvement in the insulin sensitizing adipokines with weight loss. So to summarize, adipokines are the central regulator of the crosstalk between this adipose tissue, immune pathway and the metabolic organ. Imbalance between these adipokines, pro-inflammatory and anti-inflammatory, drives this meta-inflammation, insulin resistance and cardiometabolic complication. And this marker are originating from the dysfunctional adipose tissue, where the development and progression of type 2 diabetes, cardiovascular disease and MAFLD can be tracked, and improving the pathophysiology of these adipokines and risk stratification are the novel therapeutic target in future for diagnosis, treatment and prognostication tracking of your patient, and the knowledge of adipokines in and meta-inflammatory will lead the future of management of metabolic dysfunction. Thank you for your kind and patience.
Thank you, Dr. Ritesh, for finishing well within time. and taking us into the depth of the pathophysiology of adipokines. I think precision obesity is something where probably another 5 to 6 years from now we will be having a far more better approach than what it is currently. Thank you. The house is open for discussion. One question.
My question is anti-inflammatory agent. Methotrexate is futile, but what is the role of colchicine?
In the management as a colchicine as an anti-inflammatory, I will not go in detail about the molecule because I am not part of treating this type of patient. But what I think colchicine as an anti-inflammatory molecule, it will definitely improves the adiponectin level and decrease the leptin level to give the patients better outcome. But
Yeah, I think, Dr. Sir, very good question. Sir, we can say methotrexate is not very useful because there was a Cantus trial. You might know the Cantus C and Cantus trial, which did, they gave methotrexate for the myocardial infarction because they said the infarctions are because of inflammation and they produced good result. There's a different discussion. Colchicine I had not tried that way. The point that I wanted to make that when Ritesh you say there's a meta-inflammation, you mean slow,
yes, sir.
slow
Chronic inflammatory
chronic
condition.
inflammation. And if you want to prevent at that stage a disease, I mean, shall we give anti-inflammatory cytokines or what is the way? I mean, let us have a clinical utility of those, said like as you rightly said, adipokines, will it help? I mean, just wanted to know. I have not gone deep into it. But I know that meta-inflammation is the cause for many diseases, even beyond cardiometabolic, like
Yes, sir.
rheumatoid arthritis.
Rightly
It's
said,
also
sir.
inflammatory.
Rightly
so,
said.
I mean, meta-inflammatory.
So,
So,
in
what's
fact,
your comment on that?
in fact, in this inflammatory arthritis cases, now the interleukin 1 beta antagonist, that is the anakinra, is now available. Patients are taking.
Correct.
So, meta-inflammation is both. Either you need to decrease the pro-inflammatory cytokines or increase the anti-inflammatory cytokines. There are ways where lifestyle modification and exercise has also shown in that regards. Pharmaceutically, we have GLP-1, metformin and thiazolidinediones, and newer research are going on with this adiponectin analog, FGF21 analog and interleukin 1 beta antagonist.
I think we'll close by saying that we know today that the meta-inflammation drives the metabolic disease. It's
Yes,
a
sir, rightly
current
said.
statement. So I
Rightly
think
said.
that you also said metabolic, the meta-inflammation drives diabetes, heart disease, hypertension. They drive the metabolic disease. Number two, anti-inflammatory strategies are essential. As you said, new drugs are coming. So it is worthwhile to know what helps, like adipokines help. As you showed, some other things do not help.
Yes, sir.
Bispartin, statin, they don't help. So it is worthwhile knowing and how to take it forward. Thank you very much.
Thank you, sir.
Thank you, Dr. Ritesh. We now move on to the next session. I'd like to invite my friend, Dr. Prashant Shankar from God's own country, Kerala. He will be talking about a very important topic. I think we have seen quite a lot of papers on this in the past 3-4 years. Insulin resistance and steatosis, FIB4 and APRI in our clinical practice. He needs no introduction. I think we'll directly go into the session.
Thank you, Suraj, and thank you, chairpersons. And first of all, I would like to thank Supratik once again for giving this opportunity. So I have been given a very specific and important topic, that is insulin resistance and steatosis. The role of FIB4 and APRI in the assessment of these two things. Why this matters in 2026? Because we know that MASLD is very common, and fibrosis drives the outcomes of MASLD, and steatosis alone is not the prognostic pivot. And fibrosis stage most strongly predicts liver-related morbidity and mortality. And we need a scalable triage, and guidelines now endorse a stepwise strategy rather than doing all the investigations together. So the learning objectives would be explain the mechanism, how insulin resistance drives steatosis and why fibrosis is the key prognostic pivot. calculate and interpret these two tests, apply the guideline-based pathways, and recognize the pitfalls and gaps in interpreting these two investigations. So this is the global epidemiology of MASLD, which we are all aware about, and it is growing day by day. And coming to India, we have the burden of diabetes, which is huge, and from a primary care point of view or from a diabetology clinic point of view, type 2 diabetes is a major independent risk factor for MASLD and advanced fibrosis, and insulin resistance is the shared metabolic driver, and ALT can be normal even with significant fibrosis in type 2 diabetes. Very often the investigation show that the ALT, AST levels are within normal range despite the patient having significant fibrosis. And fibrosis screening is not yet standard in most of the Indian diabetes care bundles, especially in the semi-urban or the rural areas. This is one of the landmark studies which was published last month. I was fortunate enough to be a part of this study, the DIAP-FIB liver study, which showed that this is an elastography-based study reported in people with type 2 diabetes, which showed that 1 in 4 people with type 2 diabetes have clinically significant liver fibrosis, and 1 in 20 has possible cirrhosis, and a good number of people are undiagnosed. So the clinical imperative is that this evidence argues for a fundamental shift in our approach, and the focus must move on from fatty liver detection to fibrosis risk stratification as a routine component of diabetes care. So fibrosis first in diabetes should be the central message. So coming to the pathophysiology, how insulin resistance loads fat into the liver. As you can see, adipose insulin resistance increases the lipolysis and free fatty acid flux into the liver. Simultaneously, hepatic insulin resistance occurs alongside the hyperinsulinemia. Yet, paradoxically, there is a hepatic de novo lipogenesis which can remain active, which is something like a selective insulin resistance, and it adds to the intrahepatic triglycerides. This dual mechanism is supported by the human mechanical works. So another slide on the selective insulin resistance or the de novo lipogenesis, which keeps on running. This is a paradox. In classical insulin resistance, the glucose uptake is impaired. However, the hepatic de novo lipogenesis persists despite the insulin resistance driven by continuous insulin signaling. What results is that there is intrahepatic triglyceride accumulation from both the incoming free fatty acids and the ongoing de novo lipogenesis, which amplifies the steatosis beyond the free fatty acid flux alone. So again, which means that the ALT can be normal, steatosis can be missed on an ultrasound, but the fibrosis risk persists, especially in people with type 2 diabetes. So this is the injury cascade from the lipotoxic stress to the inflammatory signaling. There is the stellate cell activation, and once the hepatic stellate cells are activated, it drives the extracellular matrix deposition and progressive fibrosis. And the steatosis itself is not always toxic, which explains why every person with a fatty liver doesn't progress to fibrosis. There are multiple factors which play in the progression of simple steatosis to fibrosis, and the activation of the stellate cells is which brings about the fibrosis and further advances. So this is why fibrosis is the clinical pivot. You can see that F0, F1 means there is no or mild fibrosis. Again, this is the time for primary or primordial prevention. The metabolic risk should be managed. The patient should be advised to avoid weight gain, and there should be periodic rescreening. F2 is moderate fibrosis, increased liver-related risk. Consider a hepatology input, and there should be intensified treatment. In advanced fibrosis, there is high risk of progression. This is where we should be very cautious, and there should be hepatology referral and surveillance planning. And cirrhosis, this is just damage prevention, and the patient should be under complete hepatologist surveillance, and it should be a specialist-led care. So 2 and 3 are the areas which should be targeted. So where do the non-invasive tests fit? The positive predictive value and negative predictive value depend critically on disease prevalence. So in unselected at-risk populations, advanced fibrosis prevalence can be less than 5% in NAFLD and less than 10% in alcohol-related liver disease. And this is where exactly the rule-out strategies shine. So the first thing should be the blood scores, which are very simple, cheap, scalable, and best to rule out in primary care and endocrine clinics. Elastography should be the second step, which measures the liver stiffness, and biopsy would be the last step in selected cases. Coming to the FIB4, you can see the formula for FIB4. It involves the age, the AST, platelets, and ALT. And these are simple tests which can be ordered at minimal cost. It is available universally in most of the labs, if not all the labs. And you can see the derivation and validation of these tests. These were originally developed for HIV, HCV co-infection cohorts. And you can see in the original study, the OROC for differentiating fibrosis was 0.76, which is reasonably good. Anything more than 0.85 is excellent. And it has got a good negative predictive value and specificity. Negative predictive value if it is less than 1.45, and high cutoff 3.25 has got high specificity. This is for the initial validation. Now it is validated across the MASLD spectrum in type 2 diabetes population, and it is endorsed by most of the national and international associations. So this is the current cutoff zones and age effect. Less than 1.3 means low risk. It rules out advanced fibrosis, and you have to manage the metabolic risk. Indeterminate is 1.3 to 2.67, where you need to have a second line testing, preferably the fibroscan, along with lifestyle trials. And high risk is more than 2.67, where you have higher likelihood of advanced fibrosis. You have to refer for hepatology and confirm with elastography. And there are a few caveats. Age more than 65 years, the false positive increase with age, and even then, the EASL MASLD guidance recommends using more than 2 if the patient's age is more than 65 years. And AASLD notes that there is a reduced accuracy in less than 35 years. So this is the accuracy in MASLD and type 2 diabetes. Again, you can see the OROC is 0.75 if for cutting in ruling out fibrosis, and it is very high, 8.85 when the cutoff is more than 2.67. So the low cutoffs protect the sensitivity and it rules out fibrosis, and the high cutoffs protect the specificity, it rules in fibrosis. And many patients who fall in the indeterminate group, they require elastography. So these are the pitfalls. There is an age-related inflation. Acute hepatitis can falsely elevate the results. There is a platelet confounding factor. The other causes of thrombocytopenia should be ruled out. And the EASL cautions that even after all these things, there can be a 10% missed rate in patients with advanced fibrosis. APRI, again, this is the formula for APRI. It uses AST, the AST upper limit of normal, and the platelet count. Again, it was originally developed for chronic hepatitis C, and these are the interpretative thresholds for APRI. You can see that APRI less than 0.5 has got a higher negative predictive value for ruling out significant fibrosis. APRI more than 1.5 has got a higher positive predictive value for ruling in significant fibrosis, and APRI more than 2 is more specific for cirrhosis but has got a low sensitivity. But coming to APRI in NAFLD, this is the reality check. If you compare the OROC comparison in MAFLD, the more the OROC value, the more is the applicability of this test in discriminating whether this is a significant disease or not. So an APRI anywhere it's more than 0.8 or 0.85, it shows significant, it is very significant in, which means that investigation or that modality is highly discriminative. So in NAFLD, you can see that the APRI fares less or it is less significant compared to the the other test, which is FIB4 score. So why APRI underperforms in NAFLD? It relies heavily on AST elevation and the upper limit of AST, which can be different in different labs. So it is currently it is best framed as a secondary or a backup score or a cross etiology bridge for clinicians already using hepatitis C workflows, and it is not the ideal tool for fibrosis in MAFLD or MSLD or diabetes. So this is a comparison of all those what we have talked about. You can see that the FIB4, what it measures, and the role of FIB4 and the key thresholds and the main limitations. APRI, as you can see, there is an upper limit of normal variation, the weaker OROC, and the platelet confounding is there. FibroScan, again, there can be false positives with inflammation, cholestasis. It requires a 3 hours fasting, otherwise it can give falsely elevated results. Liver biopsy is the gold standard, reserved as the last result. It is invasive, cost is involved. So this is the guideline-based stepwise algorithm. You can see it should be, the step 1 should be the identifying the at-risk patients with type 2 diabetes, obesity, metabolic syndrome, and abnormal LFT. Then we have to calculate the FIB4 using the AST, ALT, age, and platelet. Step 2, you have to rule out those patients at low risk with FIB4 and manage with preventive measures. Step 2, again, the indeterminate group, you have to proceed with FibroScan. And step 2, if in the high-risk patients, you have to refer for hepatology for further detailed evaluation. And some of the new international guidelines, they advise skipping the, whenever there is a feasibility for FibroScan, they advise skipping the FIB4, and you can directly go into the FibroScan wherever it is available. So a couple of cases, you can see this is the application of these two scores. A young adult with metabolic risk and low fibrosis risk. This is a 38-year-old female with who has got PCOS, overweight, mild ALT elevation, and no alcohol risk. You can see the AST is 40, the ALT is 62, and the platelet is normal. If you calculate the FIB4, it is 0.69, again, which falls in the low risk. So again, this patient is in the preventive cohort. And you have a second patient who is 52-year-old, type 2 diabetes for 8 years, central obesity. There is no decompensation. Again, the AST, ALT are elevated. The platelets are in the normal range. But if you calculate the FIB4, it is in the indeterminate range. So this patient ideally needs a VCTE or a FibroScan. And if you assume that it falls in the 9.5 kPa, this patient is at moderate risk of fibrosis, and this patient should have intensive lifestyle management with or without medications. Case 3, you can see it's an older adult where there is a stronger signal for advanced fibrosis. You can see that's a 70-year-old male with hypertension and fatigue. The AST is more than ALT. Platelet count is reduced, and definitely in such patients, the FibroScan, the FIB4 will be very significant. It's more than 6, which virtually puts the patient at advanced fibrosis or cirrhosis, and this patient will be having, definitely will be having a very high score in the FibroScan, and this patient will need active intervention. Even though there is an age confounder, the value is so high that advanced fibrosis can be diagnosed. So coming to the final slides, there are controversies and pitfalls. FIB4 actually rules out, not rules in. There are issues with age effects and calibration problems. Elastography confounders are not a trivia. You require 3 hours fasting before the VCTE. There are research gaps to be filled. Prospective Indian outcome studies are still awaited. There are points to be made about serial FIB4 reliability, and it has to be integrated into the health system. So these are the key take-home messages. Fibrosis should be the first thing in diabetes and MASLD. FIB4 is your first step. If freely available, it's freely available. It has got a high negative predictive value, and APRI is to be used as a backup test. And if the results are indeterminate, never hesitate to escalate to the next level. And in India, we need systematic screening. We have a huge
Thank you,
burden of
Prashant.
diabetes and
I think
MASLD.
very great lecture. And we can have one question from the audience. Dr. Sir, you see, the whole issue is that, Prashant, I think it has been recommended in the guideline, if you agree, that, FIB4, as you rightly showed that table, comparing FIB4 and APRI and saying that the FIB4 is head and shoulder above above APRI in the NPV. It rules out. I mean, then ruling in, as you rightly showed. The whole issue is that many places do not have the entire gamut of things to do FIB4. Even though we work in medical colleges, so we say 1.3 cutoff is the ideal. So APRI is more useful the places where it rightly is not a replacement for the FIB4, but more useful where do not have the facility to do FIB4. And I personally believe that the latest machines which are coming, echo machines, do have built-in VTCE. So therefore, this may, in next 10 years, may become a super. But today, we need it. I do not know fibrosis is very much dependent upon the observer who does the thing. But I think FIB4 is absolutely in numbers. So you cannot change the AST value, ALT value, you cannot change the age. So that's why I like FIB4. Over to you, sir. One question. Be very brief, sir. You are audible.
FIB4 value is very variable because age is variable, platelet count is very variable. How can we rely on FIB4?
No, Dr. Age is, you see, age is variable at particular stage, but we are doing the test, age is not variable. Are you getting my point? Supposing I am doing the test today on a person. No, but then it dependent, na? The number varies. I'll show you to that. We have done that paper that they published. It is supported by the industry. And we have done all types of permutation combination, finding out where it helps. I think FIB4 has stood the test of time. But as you rightly said, in the elderly people, you showed that.
Yeah.
He said elderly people. 60.
And in those less than 35 years also, it's not that
So in
relevant.
those cases, Dr. Sir, you are correct. Are you getting my point, sir? Above 65, and we say below 30, this test will not be useful. You are correct that way. Otherwise, for a particular person between 30 and 64, it is useful. That's what my submission is. Thank you very much. We'll again have further discussion. Great talk.
Thank you, Dr. Shankar. I think we'll move on to the next session. Dr. V.K. Abhichandani, sir, from Ahmedabad, will be talking about the whole crux of the conference, that is, how do you stage obesity? Am I obese? Are you obese? Is everybody obese? Obesity staging with the special reference to Indian population.
So, Honorable Moderator Dr. A.K. Das, sir,
I must tell you
Honorable Chairperson.
that Abhichandani is one of the walking, moving encyclopedia in diabetes. I knew him first when we started the public health course, and we were together in many forums, including we did voluntarily programs in Madhya Pradesh and many other states. And you see the depth of his knowledge, analysis is great. Abhi, all is yours.
I am deeply humbled by your kind words. Esteemed colleagues, over next 15 minutes, I have taken the liberty of changing the title a bit. So the title now reads Obesity Staging Reimagined Beyond BMI, Decoding the Indian Phenotype. So I appreciate the opportunity to discuss obesity staging, a field rapidly transforming clinical endocrinology. The unique Indian phenotype requires urgent attention, and I would like to share a key perspective relevant to our context. Today I will argue that obesity in India should be defined by metabolic health rather than by weight. The Lancet Endocrine Commission in January 2025 recommended supplementing BMI, which has faced significant criticism, with at least one additional measure of body fat, such as waist circumference, waist to hip ratio, waist to height ratio, or direct fat measurement by DEXA. The Commission also proposed a two-tier classification: clinical obesity, defined by excess adiposity with organ dysfunction or functional limitations, and preclinical obesity, characterized by excess adiposity without any clinical complications. So this is a borrowed diagram from the original paper. It is free to download. So as you can see, preclinical obesity and clinical obesity, both of them go through the same measurements, BMI, waist circumference, and some additional measurements. And the pathophysiology starts with alteration of cells and tissues and some structural changes in the organ in the preclinical stage. This will augment to the genuine organ dysfunction and maybe end organ damage in the clinical obesity stage. And the clinical manifestations are almost nil in preclinical obesity, minor or absent, because there is a substantially preserved organ function. And this worsens to frank signs and symptoms, limitations of daily activities, and complications when the clinical obesity stage sets in. And the detection and diagnosis is with the help of anthropometrics, medical history, review of organ systems, and further diagnostic assessment as needed. However, this particular classification attracted its own some criticism. So Professor Ranganath Muniappa, from the National Institute of Diabetes and Digestive and Kidney Disease in Bethesda, Maryland, had three main concerns with this framework. So what were these? So it is often difficult, the first one, difficult to demonstrate that organ dysfunction is directly caused by excess fat, which may delay timely weight management interventions. And there are conceptual challenges in defining preclinical obesity, as well as in the exclusion of type 2 diabetes from the list of obesity-induced organ dysfunction. So this particular Lancet endocrine recommendation had excluded type 2 diabetes in the preclinical stage in the list of possible dysfunctions, future dysfunctions. And then lastly, anthropometric measures of adiposity are often poorly standardized and inaccurate in most primary care settings. So these were the arguments put forth by their American colleague of Indian origin, Professor Ranganath Muniappa. Now I will change my attention to the Indian perspective. So in India, obesity should be recognized as a phenotype-driven, adiposity-based disease that requires assessment beyond BMI. I am sure all of you will agree to this. The increasing recognition of a lean diabetes epidemic in India challenges the traditional use of BMI as an indicator of obesity and risk. Many Indian individuals develop type 2 diabetes and CVD, that is cardiovascular disease, at BMI levels considered normal by global standards due to higher visceral adiposity and greater metabolic vulnerability. The Indian phenotype is unique and is often referred to as the thin fat Indian. And this term was coined way back in 2003 by Honorable Yajni sir in his landmark study, the Pune Maternal Nutrition Study. So this clinical paradox emphasizes the need for more nuanced phenotype-based risk assessment. Is BMI failing us in head? This is good. Okay. So is BMI failing us in India? We see patients with a BMI of 22 developing diabetes, muscle, and cardiovascular disease. At the same time, some patients with higher BMI remain metabolically stable. So the real question is whether we are accurately measuring obesity or overlooking it. The Taylor twin cycle hypothesis explains type 2 diabetes because of ectopic fat in the liver and pancreas and not just overall obesity. Liver fat drives insulin resistance and excess glucose production, while pancreatic fat impairs beta cell function, creating two self-perpetuating cycles. This is particularly relevant in Indians who develop diabetes at lower BMI due to higher tendency for ectopic fat deposition, highlighting that fat distribution, not weight alone, drives risk. So in India, measuring waist circumference may provide more valuable information than using a weighing scale. this phenotype is not merely anatomical, means it's not just depositing in liver, pancreas, and the story is over. No, but it is biologically aggressive, characterized by early insulin resistance, ectopic fat deposition, and a pro-inflammatory milieu. So clinically, this will drive a heightened risk of early onset diabetes, muscle, and cardiovascular disease. Now, a quick look at UOSS, that is Edmonton Obesity Staging System, which was proposed way back in 2009. And later in 2022, our own Endocrine Society of India had their own indicators to define obesity. If you see the body fat, not taking. So body fat percentage, more than 25% in men and more than 30% in women. And again, 23 and 25 kilogram per meter square were two different cutoffs adopted. So EOSS predicts outcomes, whereas BMI predicts categories. The ICMR, this picture dramatically changed with these recent developments. The ICMR India study highlights a significant finding. Nearly 43% of Indians are metabolically obese despite being non-obese by BMI. This group is known as the monophenotype, which refers to metabolically obese, non-obese individuals, and it is the silent majority. The most dangerous obesity in India is often invisible to the BMI measurement. Evidence shows that mono individuals have a higher risk of central obesity, diabetes, CVD, and CKD. Sometimes this risk exceeds the risk enjoyed by overtly or suffered by overtly obese individuals. Early recognition thus provides a crucial window for timely lifestyle intervention and targeted therapy, which may prevent progression to irreversible complications. Mono underscores, very importantly, the urgent need to move from a BMI-centric approach to a phenotype and risk-based strategy in India. These individuals are classified as stage A, hidden risk, or stage B, early metabolic disease, because they already have cardiometabolic dysfunction, even if they do not meet traditional criteria for obesity. This group represents a significant missed opportunity, as they are often not identified, screened, or treated early due to their normal weight level. So why BMI is inadequate? BMI does not distinguish between fat and lean mass. BMI does not account for fat distribution, ethnicity, or metabolic health. BMI measures body mass, not metabolic risk. So now we come to the new Indian consensus introduced last year, again by Professor Anup Misra sir and the Indian Obesity Commission members. So it introduces a staging system where stage 1 is BMI more than 23, no functional impact. Stage 2 is BMI more than 23, plus abdominal obesity, plus dysfunction, plus possibly comorbidity. And this really very well integrates adiposity with clinical impact. So obesity starts with fat, but turns into a disease when it impacts function. So this is again a borrowed and from a free to download paper. So obesity, BMI more than or equal to 23. Stage 1 is BMI, again it's mandatory to measure the BMI. Optional measurements are waist circumference, waist to height ratio, and body fat analysis. Plus, there should be no symptoms suggestive of limitations of day-to-day activities due to obesity. Plus, there should be no obesity-related comorbid diseases. When stage 2 obesity, if we talk of, we have to have BMI equal to or more than 23 kilogram per meter square, plus one of the following haywire, means abnormal measurements, waist circumference or waist to height ratio. Body fat is very preferable and should be measured by DEXA, but it still remains optional, not available everywhere. Obesity plus, there has to be obesity associated limitations in day-to-day activities, one or more, for example, shortness of breath, palpitations, musculoskeletal symptoms like pain, joint pains, lower limb joint pains, or there may be obesity associated comorbid disease, which can be multiple or just single. Type 2 diabetes, CVD, hypertension, OSA, muscle, dyslipidemia, osteoarthritis, mental health disorders including depression, anxiety, and low self-esteem, infertility, please mark this, and polycystic ovary syndrome. So, Honorable Moderator Sir and Honorable Chairperson, our classification is really way ahead of even Lancet effort. I think we have done one-up stuff. So this revised framework aims to enhance early diagnosis of obesity and related health risks among Asian Indians in India. It provides tailored management strategies for more effective care and aligns well with global initiatives which were again introduced the same year 6 months earlier, redefining obesity. And so beyond BMI, this is my humble recommendation, sir, my humble proposal. A practical framework for obesity staging should include 4 key areas: adiposity, function, metabolic health, and risk. These elements together, I believe, reflect the true complexity of obesity. The main point is that obesity is not defined by single number, it is a multi-dimensional disease. So, and there are some clinical domains of staging which include metabolic issues like type 2 diabetes, dyslipidemia, mechanical issues like osteoarthritis, OSA, mental issues like depression, and milieu, the 4th M, is the lifestyle. If it is erratic, then only means that patient is not going to easily get control. What about screening? Screening patients, we should screen patients using additional measures beyond BMI, including waist circumference, glucose levels, lipid profiles, and a comprehensive risk assessment. The ADA Standards of Care 2026 recommend screening high-risk individuals in Asian populations at lower BMI thresholds. Treatment implications. So early intervention should include lifestyle modifications, pharmacological treatment, and strategies especially aimed at reducing visceral fat. In the Indian context, early intervention is considered appropriate rather than aggressive. So I think we will all be justified in approaching our patients in a significantly aggressive manner. So my take-home messages from my humble presentation: from the ICMR India data to the STEP and SURMOUNT trials, there is a wide range. We are witnessing a significant shift in how obesity is understood and managed. BMI underestimates cardiometabolic risk in the Indian population. Abdominal adiposity is a primary contributor to disease development. The metabolically obese normal weight, that is the monophenotype, is predominantly evident and present in our population. Disease staging should incorporate both functional and metabolic parameters, and a population-specific framework is required for India. So thank you very much for your patient hearing. And if there are any questions, criticism, comments, everything is there.
Sir, wonderful, really wonderful discussion, sir. I think it deserves a big round of applause. Sir, measuring scale should be replaced by measuring tape. I think that is what you are trying to tell. Sir, I had one small doubt of my own. Sir, do we incorporate the body fat analysis in our day-to-day practice, or should we
still
still
readily
wait?
available? It's not easily accessible, at least in peripheries. So whenever the body fat analyzers and calibrated and endorsed analyzers, if they are available, we do use. And in Ahmedabad, I think Rutul is also having, my esteemed colleague, and Vipul and Dhruvi, they are also having a very good quality body fat analyzer, which is the results are quite reliable. So, otherwise, learning to use a measure tape and other ratios is also good enough.
I think what is the beauty of your presentation, Dr. Sir, is that you are given the directive for a new type of staging and classification. Now, and you have also pointed out the rural-urban divide, which we wrote in the ICMR in-depth study.
Yeah.
As you are aware, sir, I chaired the ICMR in-depth study, and latest we have
Yes.
published a series of papers. I'll just highlight that for you. 1 minute, take only 1 minute. Now, we have said that in Indian population, Avi, the
Yes, sir.
abdominal obesity is 40%. To be exact, 39.5%. Or abdominal obesity is 40%. If you look at the general obesity, is 28%. And that is the finding of the 1,20,000 population. Number two, we have said the, the most common type of obesity we have is mono, as you rightly pointed out, metabolically obese but non-obese.
Non-obese.
To look at very fat, don't go by the appearance. I think many people will fall for Rutul. Rutul might be having a lot of visceral fat, who knows? So it is called monotype obesity. Now, I'm not taking over the chances, Rutul. Now, the other type of obesity is metabolically obese obesity, MOO, M-O-O, and it is a type of obesity which is found in the people who have type 2 diabetes, who have lot of comorbidities. Am I correct, Dr. Sir?
Yes.
But there is a divide. We found in our study that the majority of the mono, that is metabolically obese but looking normal, is in the rural areas. But the urban areas have a large number of people who have this MOO. They are obese to look at and metabolically also obese. So we gave a call that we said that metabolically obese, non-obese to look at is 43.3%, and and therefore we have the overall obesity is rising rapidly, but it is distinctly trend in the urban areas because they get into more complication, heart attack, things like that. And also few in the rural areas. Females have significantly higher rates of abdominal obesity. It is 50% in the females obesity. And if you look at the regional variations, which is an all India study, we found Punjab, Chandigarh, Delhi, and of course Prashant, Kerala has high rates of obesity. And therefore, these findings, we said, to emphasize need for a focusing on metabolic health rather than only on the body weight. So we say, as Dr. said, that look at the person, metabolic health, than the body weight. And that is why Abhi has given this new, but I think there are so many subjective things that he has, say, lifestyle milieu, very difficult to assess, sir. Am I correct? To do he said from each area, he said two diseases. He said for the mental health, he said depression and something.
Anxiety, depression.
Anxiety, depression. How to find it out to put it in the classification? So application, but I think Abhi is at it. We'll be developing it shortly. It is also published now. Therefore, I think not the entire thing is published, but new ideas are published. Am I correct? That paper you.
Yeah, one of the papers is carrying a small paragraph mentioning this.
Mentioning that. So we have to little refine it.
Yes.
And find out ways to do it. Now, Dr. Saab asked about the
fat analyzer.
The Ahmedabad and Gujarat is a different kettle of fish for many regions. I will not tell the regions. So it is a many regions. You know, that bariatric surgeon, what's his name? Rutul? Bariatric surgeon?
Mahendra Narvaria.
So he has put in airport 18 machines all over Gujarat. Am I correct?
Yes.
He has put machines in the airport to check, and he has also asked to put one in my place. I have requested him. You know, so they have, Rutul must be having, and you know, people do small impedance machines costing 1 lakh, 2 lakh, 3 lakh, 4 lakh. But I have come to opinion that machines below 8 lakhs do not give publishable values. You must do test to publish the values. No? So at least you buy a machine or take. I'm not advertising for InBody. I'm not advertising for them. Please don't do that. They're here in the conference. But I must tell you that a good machine costs 8 lakh. That's what we said. It may not be available worldwide. Yes, Rutul.
Yes. Sir, it was really indeed
absolutely
pleasure.
Fabulous presentation.
Yeah, it was indeed pleasure to have two gurus, A.K. Das sir and Abhichandani sir, who is also my teacher. He has been my teacher. So what we are talking is more. We have more and more mono cases. Around 40% obesity is there with abdominal obesity. But how to convince them is a bigger problem, because most of our patients with BMI of 27 or 28, they are comfortable. They don't want to reduce weight in any case. So for that, we need to do something or need to spread awareness. I don't know how to do it because this is the clinical challenge. This is not about numbers. And in clinical practice, it is becoming difficult. I'm not talking even about 25 BMI. I'm talking about 27 and 28 BMI. So some practical tips from your side that how to convince them that you need to reduce weight by 3 or 4 kg, 5 kg maybe.
I have a simple formula, Rutul.
Yes.
It is a heartless formula. I say the length of your life is proportional to, inversely proportional length of your belt. That gives the message. You know, from this time of Nachiketa, of Jamas till today, people want to live longer. Am I correct or not? So you give them that the longer the belt, shorter the life, they will keep their abdominal obesity at least smaller.
So I'll make this poster with belt size.
It is not patented.
In my
but you
clinic.
can pay me some money afterwards. It's not patented. You can do it. Absolutely. This was science. And the second thing, I must tell you that the ISO in-depth study, we have, Mohan has already written, I have endorsed it, that we want to have a great dissemination meeting. Dissemination meeting means we will disseminate our finding and the news for the public. So we are inviting all the health secretaries and DGHS, and it will be held in Delhi. The cost will be borne by the state governments for their coming and going. We'll provide the central support, and this will be broadcast to the nation. And it will be not one day, it will be 2 days. So every finding of the I7 India, including this finding which you rightly quoted, mono being the highest, mono being the greatest culprit, will be broadcast to everybody. I think that will be a good thing that we have planned.
Wonderful initiative. It is much needed, sir. Thank you.
So, Rutul, very quick, humble suggestion. I would, in my clinic, never use the word obesity, weight, overweight, nothing. So I will, initiate my conversation in this manner. Can I discuss some health tips with you? So that's how you have to break the ice. The moment stigma steps in, it's a dampener. A very nice role play session is there. So in the afternoon. Thank you so much. Thank you very much, sir.
Thank you. The next session.
Yes. And we are all waiting for the next session. And the next session is the session on the initiating it's the most important session, one of the most important sessions. Initiating pharmacotherapy, when and how to choose. Number 2, what to do when the patient reaches the desired weight. So to give the drug or when stop it. Evolving pharmacotherapy, what is new. So it is absolutely fabulous session. And I'll now request chairpersons Rutul and Debashish to kindly come to the dais.
Dr. Rutul, thank you, sir. Dr.
And
Rutul Gokalni,
great thanks to our chairperson.
who is a Chief Diabetologist and Managing Director of AEC Diabetes Center, National Executive Committee and member of RSSDI. And our very own Dr. Debashish Basu, sir, who is a consultant, chairman of the Metadona Foundation and senior consultant at Apollo and Manipal Hospitals. Over to you, sir.
Nothing is more a pleasure to take the baton from my teacher, my examiner. The endless list continues. So we have. Initiating Dr. Golkani is my co-chair, and we are meeting. I think we have met many times. So it's a good gathering. It's a good fellowship that Supratik and team has organized. We are running trifle late, so we'll come down directly to the conclave series session 4. We are chairing with Sir as the moderator. We have the first speaker, Ripun Barpuzari from Shivsagar. Please. Thank you, sir. The topic is initiating pharmacotherapy, when and how to choose.
Good morning to you all. I'm really elated to have Professor Ikedas over here as a moderator, and my respected Rutul and the Basis as chairperson. So I'm basically a clinician. I'll tell each and every word in a clinician perspective. So initiating pharmacotherapy, why, when, and how. So these are my outlines, why, when, and how. So we know obesity is increased adiposity with negative health impacts. But have you seen the latest prediction by WHO in 8 December 2025? Even the relative expansion of production of GLP-1 therapies are projected to reach fewer than 10% of the total obesity burden throughout the world. And more worrying factor is that in 2024, 35 million children under the age of 5 were overweight. Over 390 million children and adolescents aged 5 to 19 were overweight in 2022, including 160 million who were living with obesity. So what does it reflect? It reflects absolute lack of awareness among public healthcare providers and specifically the parents. And the second factor, we do have our therapeutic inertia to take up a case of obesity. So when the clinical criteria in Indians or South Asians, BMI over 27.5 or over 25 kg per meter square with one at least obesity-related complications, failure of lifestyle modification for more than 3 to 6 months without losing less than 5% of weight. And when you have the early detection of non-responder, failure to lose weight by more than 5% within 12 weeks invites reassessment. But look at the other scenario. ADA Obesity Association, they published in January 2026, they have emphasized early intervention shift towards earlier proactive initiation of pharmacological treatment to improve metabolic outcomes rather than waiting for failure of lifestyle modification. And prioritize efficacy. When you find diabetic is a complication of obesity, then prioritize treatment of GLP analogs or the twin incretins. Comorbidity driven in case of atherosclerotic cardiovascular disease, heart failure, and preserved ejection fraction failure, metabolic liver disease, you need to choose the treatment earliest. So medication should be initiated alongside lifestyle changes to treat obesity as a chronic relapsing disease with a focus of attaining at least more than 10 to 15% of weight loss. Whatever the Indian scenario, as F.K. Sandani sir has just told you, that the Indian scenario is totally different. We have learned a lot from you, sir. It's more central obesity where BMI is less reliable. Other metrics like weight-height ratio and weight circumference must be measured. In fact, the weight-height ratio is not considered more reliable than WHR, weight-hip ratio. Even weight circumference sometimes, because it has no sex specificity, no ethnic variability, and universal cutoff is 0.5. If it is more than 0.5, we take it in the take care range, and more than 0.6, we take it in take action range. So reliability to atherosclerotic vascular disease, heart failure with preserved ejection fraction, and mass is strongest with waist-height ratio. So take home, more than 5% is beneficial, more than 10% is recommended with obesity-related complications, and maybe necessary in some cases muscle heart failure. Early pharmacotherapy prevents the progression from metabolically healthy obesity to target organ damage. Pharmacotherapy needs continuation with follow-up at regular interval, but why it should be continued for a long time? Because, obesity is a chronic relapsing disease. The more the fat loss, more is the chance of weight regain again, irrespective of the way you lose the weight. It has been observed that for every 1 kg weight loss, the body increases appetite by more than 100 kilocalories per day above the baseline, creating a massive biological drive to regain weight. So many mechanisms. I'll just cut short. We do have the CD4T mediated obesity memory. On the negative side, the more the weight accumulated, more the fat accumulated, the more is the presence of CD4 monocyte in the bone marrow. So they stimulate fibrinogen growth factor 2, and that stimulates adipocyte cell to cause adaptive thermogenesis. So that will increase the resting metabolic rate, so combat it against the weight regain again. The weight regain, those people who are on Mediterranean diet, they have the very beautiful gut microbiota, mostly combining Akkermansia like gut microbiota. So it is seen that the people who gain weight, if they do have the autologous transplantation of that favorable microbiota, they can resist weight regain. Free fatty mass loss is directly proportional to weight regain. Activation of thyroxine, stimulation of the neurons. So they activate the agar-related peptides, the oroxygenic peptide in the hypothalamus. So increase hunger. And this is a little wrong. This is short postprandial neurotensin peak can revert to weight loss, weight regain again. So maintenance of weight is necessary with continued treatment. And it has been observed, even in Silverstein, that study was in 2020, 2000. So the patient, more than 600 patients were followed for 36 months. They have seen that patient continuing silvostrin, they maintain the weight. And none to say about the newer medication like GLP-1 receptor analogs. Sustained weight loss often maintained more than 2 to 3 years, provided the treatment is continued. So these are drugs available in India, early stage is available, and very recently in introduction, bupropion. And unfortunately, liraglutide is not yet advocated by CDSCO for obesity treatment. We do have semaglutide, tirzepatide. For the syndromic obesity, we do not have setmelanotide yet in India. So aim for at least 5% weight loss, behavioral modification is enough, nutrition is enough. Pharmacotherapy can reduce 5 to 15% with all the medications available with us. Endoscopic surgical can reduce by more than nearing 30%. So determine the goal, how much weight you want to reduce in a particular patient. So anti-obesity medication is continuous requirement with dose adjustment along with lifestyle changes, nutrition, and intensive behavioral approach. Start along with LSM as soon as after good counseling with the patient. Determine the goal to reduce weight in percentage of the weight. So if you require 5% reduction for hypertensive, then pre-diabetic, you can choose any medicine. 5 to 10%, yes, definitely there are some better medications like GLP-1 receptor agonist. 10 to 50%, you can reduce obstructive sleep apnea, GERD, urinary incontinence, NASH, cardiovascular disease, and knee osteoarthritis. More than 15, 20%, even CV mortality can be reduced. There is signs of type 2 diabetes remission and hepatic steatosis. More than 20%, advanced preserved ejection failure, advanced type 2 remission, and postural instability. So these are the drugs. So you can see 6 to 12 years, the green line. If the BMI is more than 95th percentile, 12 to 18 years, the blue line, adolescent, and over 18 is the red line. So if the child with obesity, marked hyperphagia, congenital melanocortin receptor 4 pathway deficiency, the setmelanotide is the drug of choice in all age group. And type 2 diabetes with delayed satiation, that is not satiety, satiation. So liraglutide, semaglutide, and tirzepatide. In adolescent, you can start with liraglutide. Excessive hunger, binge eating, sleep apnea. You do have the phentermine Topiramide is not, unfortunately, it's not available. You can go for tirzepatide or GLP analogs. Food craving, naltrexone, bupion, because this is, we call it a hungry brain. Fullness desired, you can go for hydrozole. Some pellets are being introduced orally. They can reduce the stomach size and your craving is cured. So high fat food preferential, you can go for listed. So dopamine drive-in reward, or what they call it, hungry mind, hedonic eating. So naltrexone, bupion is drug. Rapid gastric emptying, postprandial hunger, GLP-1 receptor analogs, and dual agonists, hungry gut. The low BMR, often we come across the people with a very lethargic, obese, and their thyroid function is normal. The sleep patient is absolutely disturbed. These are patients supposed to have low BMR, low resting metabolic rate. So select the patient accordingly, exclude the possible disorders, and treat accordingly. So how the phenotypic based selection, what the guidelines say. I'll go the Obesity Association ADA without oversee, weight reduction, obesity medication beyond 3% weight loss with lifestyle changes, maybe up to 5 to 6%, high with tirzepatide, semaglutide, moderate with phentermine, topiramide, and modest with this medication. With obesity-related complication, if it is pre-diabetic, then tirzepatide, semaglutide comes first. The others are B categories. Type 2 diabetes, of course, the tirzepatide, semaglutide, and liraglutide. Hypertension, tirzepatide, semaglutide, all listed have so many references that it can reduce hypertension. But phentermine is contraindicated. Liraglutide, tirzepatide, evidence B. Then atherosclerotic vascular disorders, semaglutide, liraglutide, tirzepatide are not yet been included in the ADA guidelines. With preserved ejection fraction heart failure, semaglutide comes first, followed by a B-level indication in tirzepatide. Reducing mass, semaglutide comes first, liraglutide and tirzepatide, B evidence. Mass, semaglutide, tirzepatide B, liraglutide C. OSA, only tirzepatide has got some evidence against obstructive sleep apnea. Osteoarthritis, again, semaglutide, not a single diet can cause faint remission in osteoarthritis. The semaglutide, tirzepatide C, liraglutide C. So basically, in case of inadequate treatment response to current medication, consider treatment intensification, increase dose of current medication, use alternative obesity drug. I leave it to the audience whether we can use any other drug in combination. Combine obesity medication with intensive behavioral training and structured lifestyle program. And another anti-obesity medication, I'm not sure whether we can continue with another medication, continue AOMN and refer to metabolic surgery, and follow up the case for 3 months, every 3 months to monitor and modify treatment. Then every 3 months for the first year, continue long-term follow-up every 3 to 6 months. But this is the SO guidelines published in March 2025. Little bit of difference. They have given the mass they have given, as you can see over here, tirzepatide is being given the first, and maybe that particular essence style was not there. So with my last slide, AOM always initiate after a shared decision, not a forced option. Explain why he needs continuous treatment. Explain all the good things, bad things about the drug, including adverse effect. Look for all contraindication of the drug to be used. Prior sitting with fruitful discussion is the most essential component. Regular follow-up, conversation yields expected results and builds confidence of the patient. With that slide, thank you very much for present hearing. Thank you, sir.
So we'll now invite questions, or we'll do it after the three speakers. We'll do this question answer after the end. So, Dr. Gokali, next speaker.
Thank you. So our next speaker is Dr. Anirban Majumdar from Kolkata. and his topic is what to do when patient reached target weight. And this is really a burning question after 1 year of GLP-1 and tirzepatide, especially semaglutide and tirzepatide launch, that whether we should stop the drug or not. This every now and then we hear from our patients. So over to you, sir.
Okay, thank you, and good morning, everybody. Thank you, my honorable chairpersons. So this is really a burning question. So ki korbo, once the weight loss has already been achieved, what we are supposed to do. Now, if we look into the talk, we always talk about how to lose weight fast. So this is always there in the net, and we always say how we can lose weight. We have lot of trial, lot of data, lot of publications, but the issue is that we accustomed to see this before and after. The slimming centers, they always post like this, what is before and what after, but very people talk about before, after, and after. So that's the very important issue. So what we are supposed to do? So if we look into the process by which we lose weight, one is definitely by physical activity and nutrition therapy, behavioral support. We know it reduces roughly 3%, 6%, 7% weight loss. The second is by the drugs, what all of you are aware of. It reduces weight to roughly around 10 to 20%, and the bariatric surgery, which reduces roughly. So these are the three basic methods by which till date we actually address the obesity. Now, if we look into these drugs, because we are discussing about the drugs nowadays, both the drug that is tirzepatide as well as the semaglutide, you can see after stopping the drug, we can see that there is a rebound rise in the body weight. So that is actually a rule rather than exception. So we expect that this will go up. And if we look into this data, the PMJ study, which actually looked into almost 10,000 participants and looked into many trials. This is a systemic analysis, and it says that the patient returned to the baseline body weight by 1.7 years. So you can see that all the efforts, all the money, and all the psychological involvement gone within 1 to 7 years. And even it fails early if you are giving semaglutide, or you can give the tirzepatide. So that is 1.5 years. Now, if we look into the data in depth, we find that when you are giving this GLP-1 based therapy or tirzepatide or incretin based therapy, the weight loss was dramatic, but the weight gain is also quite dramatic. Now, if we look into the behavioral modification on the other hand, the weight loss is modest, but the gain is also not much. So this emphasizes the importance of the psychological involvement with the weight loss program. Now, if we look into bariatric surgery, fortunately, the regain after weight loss in bariatric surgery is not very much. So that's a very important issue that its gain is roughly around 1 kg to 6 kg. That is not much, but still, even after bariatric surgery, weight regain does occur. So therefore, we understand whatever may be the method we are adopting as far as the weight loss program is concerned, we expect weight regain, but whether the patient will regain up to the level of basal level or not, that's a separate issue. So why body resist weight loss? Because of my last speaker has already discussed, because of satiety hormone, hunger hormone. I believe that mostly it works through the tryptophan hypothesis, because always body try to conserve energy rather than lose energy, because they are programmed that they should preserve energy for the time of food scarcity. Now, so after reaching the target weight, it is not the end of treatment. It is the beginning of the maintenance therapy. This concept must be clear to all of us, including our patient. So we need to re-educate the patient. I believe that these are the 5 strategies that will help the patient to maintain the weight loss. So after achieving the target weight, we should do either of these 5 things or in combination. 1, re-educate. Number 2, intensify the resistance exercise plus diet. Step down to maintenance dose. continue anti-obesity medication the same dose, and long-term follow-up early intervention if regain occurs. So re-educate means, I feel, it is the behavioral support to the patient as well as the attitude of the patient should change, that once the goal achieved, the treatment should be stopped. The patient need to understand that I am in the weight maintainer now rather than weight loser. So this must be, I think most of my patient actually after achieving some kind of weight loss, they don't come back, and they come back after 2 years with the after reaching the basal body weight from where we have started. So that's an important challenge. And we can advise the patient, let us have a smaller target of 1 kg or 2 kg weight loss in the next 1 year period of time. So that will, patient will remain engaged in some kind of weight loss activity. The second point is the exercise. So again, we have to re-emphasize that you continue the physical activity, resistance training, diet, but the most important strategy, as I have said in the previous data also, that behavioral support is one of the most important factor that will really give some benefit if the patient want to maintain the lost weight. So even if you are doing behavioral support or interactive technology or personal contact, whatever may be, you will find that the initial weight loss, whatever has happened, whatever may be the strategy you take up, the patient will gain some amount of body weight. It may not reach to the baseline up to the 30-week period when the study has been done, but still the patient actually gain the body weight. Now coming to the step down to maintenance dose. So if the patient is receiving tirzepatide, say for example 15 milligram, you can come down to the 5 milligram weekly dose as a maintenance. Or if the patient is receiving semaglutide 2.4 milligram, we can come down to 1 milligram weekly dose. But the issue is that there are a lot of studies, lot of data as far as the weight reduction is concerned, but there is no study on semaglutide or on tirzepatide as far as weight maintenance is concerned. So we don't have the data. This is the suggestion. This is, I think, we sometimes practice in our clinical scenario, but we don't have data whether really if we give a smaller dose can give long-term benefit as far as weight maintenance is concerned, because we know that if you stop the drug, there is a chance is gain in the body weight. So if we give the smaller dose here, so whether it will maintain the body weight for a long period of time or not is exactly not known to us as far as data is concerned. Now if we also, the fourth issue is that we can continue the same dose also. We may not reduce the dose, just continue the same dose, because you can see this is the step 4 data which suggests that if you continue the dose after 60 weeks or so, there is a plateau. You can see there is no further weight loss, and therefore if you continue the dose for a long period of time, I think the possibility is that the weight maintenance will be there. The last issue is that we should do a long-term follow-up and early intervention if weight regain occurs. So monthly weight for the first 6 months, and then if the patient gain 2 to 3 kg body weight from the baseline, it means it is a red flag sign. We can restart the medication again. And lastly, we can consider surgery, but people have used GLP-1 or tirzepatide after surgery, but there is no data of doing surgery after the patient failed from GLP-1 or tirzepatide. We don't have data. But quite naturally, if the patient fails, if the patient reach to the baseline, the bariatric surgery will remain an important option in front of us, because of the fact the weight regain with the bariatric surgery is minimum compared to the GLP-1 based therapy or tirzepatide based therapy. So what to do when the patient reach target weight? The answer to this question from my side is, number 1, re-educate, because it is a chronic disease and the patient needs to understand that they have to continue whatever may be the weight lowering strategy is concerned for a long period of time. Next, we may intensify the resistance exercise and diet so that the patient can maintain the body weight for a long period of time. Third, we can step down if we're using GLP-1 based therapy or tirzepatide to the maintenance dose for a long period of time to keep the body weight under control. continue anti-obesity medication the same dose, that is also an fourth option. And lastly, long-term follow-up, early intervention if regain occurs, and possibly we can consider bariatric surgery as well in these given patients. Thank you very much for your listening.
So we'll take the questions after this end of the last talk. And our next speaker is Dr. Swaraj Vardhan-Keri from Kalaburgi. And his topic is evolving pharmacotherapy, what is in the pipeline. So we are going to listen something about future, and as in other halls, we are listening about tirzepatide and semaglutide. Here, stage is on for you.
Thank you, respected chairpersons and moderators. At the outset, I'd like to thank Dr. Supratik and his team for giving me this opportunity to be a part of this wonderful conference, a futuristic conference, so to say, because we are going to see how things are going to unfold in the next probably 5 to 10 years. So my topic is from the past two very fantastic clinical topics. This is more like an MBBS class, phase 2 pharmacology class, wherein probably I'll say XYZ drugs are available and how these are going to be useful for us in our clinical practice. Currently, the Indian data is, disclaimer, currently the Indian data with these drugs is very, very minimum. So probably in the future when the trials are done, we will be in a far better position to deal with this. So currently I do not have any conflict of interest for this talk. Why this is important? Because the economy, we all know economics is the backbone for everything. So unless until we are understanding that, we will not be able to take a proper decision out of it. So the Morgan Stanley research projected a 150 billion global market for these kind of drugs. So we have, at least by the definition, we have more than 1 billion people who are obese. So we just can't, as doctors who are involved in patient care, we cannot just leave them like this and say that, okay, fine, you are obese, you are going to have XYZ complications, and then you're going to have an end result of it. So what happened after the semaglutide came? So the current first generation achievement. So what it did, it established a very strong proof of concept for durable pharmacological obesity management. Probably 5 years or 6 years before, we would not have been in a position to have this strong push for anti-obesity medicines. But with semaglutide, we have this proof of concept. Yes, this is available. You continue this for X amount of time, then the benefits are going to be seen. So this shifted the treatment paradigm from lifestyle only to medical interventions. So probably 10 years before, a decade before, we would say that yes, a good lifestyle, an aggressive lifestyle in terms of nutritional supervision, or more protein, less carbs, less lipids. So that was the kind of approach. But in the past 5 years, with semaglutide establishing its hold as a chronic weight loss management therapy, this is what the future, this is how things are going to move. So now we have a proof of concept with semaglutide, and this is going to take us further. So there are a number of studies. This is the phase 1 studies, phase 2 studies, and phase 3 studies. So phase 3 studies are the most important ones, because we have the concept that is established, and we are going to see how this is going to get better. So the drugs that are available for phase 3 studies are, we have this orforglipron, which was recently FDA approved. We have maxtotide, we have semaglutide, higher dose of semaglutide, 25 and 50 milligrams. Then we have cagricima, and again semaglutide. So these are the phase 3 trials. So how did this come into existence? As you can see, the GLP-1 receptors are the backbone of this. So we have only GLP receptor analogs, we have GLP plus, we have GLP-2 plus, so to say. And then probably we have a different permutation and combinations of this, and then take it ahead how this will be helping us and our patients in losing weight. So what is happening across the globe? If you can see, this is a very wonderful picture which shows how the different kinds of drugs are being used. 21% is only GLP receptor analogs, 16.2% is GLP, GIP and glucagon, the triple drugs. and the 16.2 is only the GLP and the glucagon receptor agonist. So this is very, very important. In India, we have only three of these studies. So in the rest of the world, there are a number of different permutations and combinations, but in India currently we have only 3. So efficacy, as from 1, 2 and 3, 1 caused 15%, 2 caused 21% and 3 has caused 29% of weight loss. So GLP monoagonist, that is semaglutide, was responsible for around 15% of weight loss, whereas the triple was almost double with 29% of weight loss. Triple agonists are approaching bariatric surgery, but the efficacy or the consistent result is seen only when the patient is on the drug. So of the drug, the previous speaker spoke wonderfully how the Nike sign comes up when you put up the weight, when you stop, the weight regain starts in a matter of 2 years, you are back to your baseline weight. So the retatrutide, the triple agonist paradigm, a single peptide agonist combining 3 pathways, GIP, GLP-1 and glucagon, which has other metabolic co-benefits like HbA1c reductions, especially in type 2 diabetes, and substantial liver fat reductions, especially in MASH and MASLD. So this was with the Triumph 4, which was released in December 2025. This was very, very important. People with this had people with osteoarthritis had a very good remission, kind of a remission for people with osteoarthritis. So the phase 2 had caused a weight loss of around 24.2 at 48 weeks with a 12 milligram dose, whereas more than 20% weight loss was achieved with 63% of the participations at the highest dose. So 6 out of 10 will have a good result. So this is a Transcend trial. The primary and key secondary outcomes, the endpoint was HbA1c reduction and weight loss. As you can see, with retatrutide of 9 milligrams, HbA1c reduction was 2% and a weight loss of 15%. So basically to say a 100 kg person will become 85. So that is the kind of this thing. And now with 12 milligram of retatrutide, they were able to lose close to around 17 kgs. A 100 kg person will lose 17 kgs. The orforglipron, the first FDA approved oral GLP-1 receptor agonist for obesity therapy. We had semaglutide, but semaglutide oral had to be taken in one particular format. Take it early in the morning with an empty stomach with 120 to 200 ml of water. So for its better absorption, and other co-medicines, for example, levothyroxine. So they had a certain dose, drug-to-drug interactions were there. But with this, those are the things which are kind of taken care of. But with this, the ATTAIN trial, we had 12.4% weight reduction at 72 weeks and around 11% across all the participants. The secondary benefits were cardiometabolic risk reduction, significant improvements in waist circumference, reduction in systolic blood pressure, and improvements in triglycerides and non-HDL cholesterol. So another very, very important thing I would I am too young and naive to have a say on this, but still 120 Indian patients with the oral Gripron study across India. Only 120 patients, and we are assuming that this is going to be reflective for the general populations. So how right are we? Because yes, it is oral, yes, it causes more than 10% of weight loss, yes, it decreases your waist circumference, it improves your lipid parameters like the good cholesterol it remains stable, the bad cholesterol decreases, the systolic and the diastolic blood pressure comes down, yes, great. But currently it is only with 120 patients across India. So will that be a reflective of to the general population? Probably only time will tell. So this is once daily oral non-peptide GLP receptor agonist in late stage development, representation from a lower BMI. This is very important. The Caucasian population or the Western population, as we all know, have a higher general obesity. So their mean BMI for this study was close to around 36, 37, whereas for Indian population it was 31 to 32. So even with that also we were able to lose the 10% weight. So weight loss at 72 weeks was 10%, HbA1c was close to 2%. India was involved, enrollment was modest, efficacy is promising. The numbers available today are global phase 3 results rather than fully published India only subgroup analysis. And even if we do the subgroup analysis, will this 120 patients be the reflective of the general population? Probably we need further studies. So safety and tolerability 5 to 10% across the studied doses with ATTAIN 1. The GI side effects we all know, nausea, vomiting was the most commonest.
pancreatitis and gallbladder, rare events observed, continued monitoring with all of the drugs that we are using. So clinical positioning, efficacy ceiling, lower absolute weight loss, 11 to 12% compared to the injectables, more than double of that. First line option for patients declining injections or seeking oral formulations, stepping stone, potential entry point before escalation to more potent therapy. So once you tell that, yes, this particular drug is there, you take it orally for a few weeks, then probably if you are responding, fair enough. If you are not responding, we have injectables. So it kind of becomes a bridge between the initiation of the more potent subcutaneous injections versus not taking anything at all. So this is another drug, that is the Cagrisema. This is amylin analog, that is cagrilintide, plus a GLP receptor analog semaglutide, which has a fixed dose combination. So efficacy assumed was with Cagrisema of 2.4 and milligrams, it was 23%, whereas with tirzepatide 15 milligram, it was 25.5%. So regulatory status currently, FDA submission completed in December 2025. Final anticipated result is in 2026. So while Cagrisema establishes amylin biology utility, higher dose combination trials and redefined level are underway to assess its full potential and competitive positioning against multiple agonists. So currently available drugs, retatrutide with close to 29%, tirzepatide with 25%, Cagrisema with 20%, tirzepatide with 21%, and semaglutide with 15%, and the orforglipron 12.4%. So this was at the end of close to around 52 weeks. That's more or less 1 year. So 1 year of continued use of these particular drugs resulted in a decrease of around, this is the percentage. So as sir said that we don't know what will happen if we stop this drug, they regain their weight back, then we send them to the bariatric surgery. We don't know what is going to happen. We also don't know whether these patients, if we are doing the dose de-escalation as sir has showed, what will happen. So will they at least maintain 50% of the weight loss that they were doing, or will they continue to lose, will they continue to gain further weight. So we all know that they are not, it's not a simple thing, you give the drug and you forget, it requires monitoring. So the newer drugs like the survodutide, up to 18 to 19% weight loss at 48 weeks in phase 2 obesity trials, mazdutide up to 15% weight loss in phase 2 trials, muscle preserving. With the GLP-1 receptor analogs, the concept of sarcopenia has gained the greatest possible momentum. Probably in the past 15-20 years that we have seen, I think sarcopenia has really come up. Probably one of the reason was because these patients were losing lean mass also. So to prevent that happening, they came up with bimagrumab plus semaglutide, which is an anti-ACT2R2 antibody with 18 kgs absolute weight loss at 48 weeks, substantial fat mass reduction with relative lean mass preservation. So other emerging target, the PYY analogs targeting appetite regulation through the peptide YY receptors, leptin sensitizers and mitochondrial uncouplers. These are more of a pharmacology driven, wherein we are understanding, we are in the phase of understanding, but the clinical application will probably take quite a bit of time to come. So triple agonists up to 18% weight loss, unique signals. That one thing, dysphagia was one very important side effect that was seen. Probably needs more look into this, how to address this. Oral GLP around discontinuation was around 10%, whereas amylin plus GLP-1 receptor analogs was around 5 to 15%. So 1 in 3 more or less will 1 in 5 will probably end up stopping the drug. So long-term safety is still under evaluation. So beyond BMI, I think that was been the talk of the whole of the conference, beyond BMI. So it's just not about weight. We look into the cardiovascular, we look into the heart failure, sleep apnea, the renal and the liver. So it is just not this drug going to help you lose weight, but what are the other things it is going to do? Even that is also very important. So challenges for the next decade: muscle mass prevention, access and equity, and durability and maintenance. I think these two things are these things are very important. I think the one that requires most important concern is sarcopenia risk. Rapid weight loss that is more than 20% is consistently associated with progressive lean mass. So probably dose de-escalation is probably the way to go ahead, or high protein diet and good amount of resistance training also will be beneficial. So anabolic adjuncts, development of combination therapies with muscle preserving strategies like the bimagrumab to target the fat loss selectively. Cost, I think probably the patency, till the patency is there, the cost barrier will be there. So this is my final conclusion. So if I have to pick up a drug for ASCVD, heart failure with preserved ejection fraction, CKD, type 2 diabetes, MASLD, MASH, OSA and body composition. So these are the drugs that I will have. So these are the ones which are preferred for so and so. For example, if I want to use a particular drug in a high risk cardiovascular disease, I will probably pick semaglutide. And if I want weight loss, obstructive sleep apnea and MASH as my target reductions, then probably terzepatide would be a better drug. If the patient is having a lot of sarcopenia like picture, and if you are able to prove clinically sarcopenia, then probably CagriSema would be the one. And if the patient doesn't want to take injectables, probably orforglipron would be an option. So again, same with respect to retatrutide, survodutide and the other incretin plus ACT R2 block. So different, again, precision obesity medicine I think would be the way to go ahead. So clinical implications, this is also more or less the same thing. You pick and choose. No one drug will suit all the patient. You have to look into the weight, the BMI, the waist circumference plus all the other comorbidities before we make one final selection of a drug. So near term, that is in the next probably couple of years, retatrutide, orforglipron and CagriSema. In the next 3 to 5 years probably long term CV outcomes. Readouts of this triple agonist are going to come. Muscle preserving combination regimens will probably be applied. We do not have any drug for the people who are less than 18 years. So that's one very, very important thing. And ICMR data also showed that the obesity, the diabetes is getting younger. Matlab, it is affecting the people who are far less younger than the patients that used to get affected probably 20 years back. So gene therapy, polypharmacy personalization, which will be directed by multi-omics, prevention focused pharmacotherapy in high risk pre-diabetes cohorts. I think this will be the way ahead to go. So again, 2 slides. Terzepatide, we have data for approximately 100 Indian patients. Semaglutide 218 Indian patients, but the newer after the patency, a lot of other pharmaceutical companies are coming up with their own phase 3 RCTs that also will probably give us more information. Thank you. This is my place. This happens around half a kilometer from my place. If you are coming there anytime, please welcome. Thank you.
Thank you. Thank you all the 3 speakers. We are actually running 20 minutes late today. I will hand over the microphone to sir.
I think this has been a fabulous session. You know, last talk really I appreciate your mastery over the subject, the amount of pain you have taken to compare and give a precision initiative to these drugs. And I think it is very important. I remember in our clinical trial, dysesthesia was very common. You highlighted
Yes,
that.
sir.
But if people see it transitory, I'm not very sure transitory or it lasted for a longer time. Now, the whole issue is that CagriSema will not come now. I'm told it will be delayed for a certain time. Now, so that we can count it will definitely come little late. Orforglipron has come, but as you rightly pointed out, the number of patients are only 120 for an oral drug trial. That's too less. But your talk was fabulous. We'll just take up speaker-wise questions. Prashant, you want to ask? Prashant can ask. Short questions, short answers, because as Devasis pointed out, it's slightly late.
Just have.
You'll be audible, Prashant.
I just have one comment about we have the higher doses of Wegovy and oral semaglutide coming up. I think that will also be added to the
I think to that answer, I think Sir will give the answer, but you know the Pioneer 8 and 9 and 10 trial, which Nitin Kapoor did in Vellore, he showed that the weight loss is definitely much more than what was achieving with 3-7-14. It was much more than that. But let me listen from you, sir. Do you believe that the high dose SEMA will be a good answer?
Yes, sir. But if we are tolerating, definitely yes. If we are tolerating the drug to that particular extent.
Number 2, as a continuance of that question, I'm very brief so that all the questions answered.
Sir.
Because you are an expert. People also, after few doses of Tirze, for about they take. I've seen in my patient average 7, 8, 9 months. Beyond that, they said give us oral, give us oral. Now if I change over to
25 milligram or 50 milligrams.
What's your opinion on that?
Yeah, definitely, yes, sir, because as we said, no intervention,
Is
oral
better.
drugs, injectables. So these are the three things. So if we can bridge it either way, start with an injectable and then settle down to an oral, or start with the oral, not responding, then probably go to a injectable. I think definitely we would be expecting good amount of weight loss.
I think your answer to your question, oral semaglutide, high doses holds promise. Before the new drugs, new high potency drugs came from the pioneer 8, 9, 10 trials that they did with 25 and 50 milligram.
25 and 50, sir.
Yeah, please.
So I feel that these higher doses are not for Indian patients, as our 20 to 30% only tolerate those higher doses which are already available. I feel they have come up with these higher doses as just one reason, because it has gone off patent, and now they want to come up with something else. So this is why they have come up with higher doses, and maybe they will not get yes.
I think that's a very good point. I think AK of this is giving a talk in the late in the afternoon today regarding this multiple sema avatars that we are seeing today, and how to decide amongst them what to take, how much to take.
Sir, probably to down titrate the discussion to metformin, sir, in my practice, I see probably 1 in 5 patients not tolerating anything more than 2000 milligrams of metformin. So that's around a 20%.
In majority of our practice, I think Caliburagi is much better. We do not give more than 1500. We do not give 2500
Yes.
out of question, 3 gram out of question.
The Westerners use 2.5 and 3 grams.
Impossible. They will not tolerate
Yes.
it. They will not tolerate. And also, I personally believe metformin is a drug which acts better in a sub-maximal dose, in a for the diabetes control.
Okay.
Now, few things were discussed. I have only 1 or 2 minutes left. Any other question to be asked? Yes, Prasant?
Sir, another question to you, sir. You know that Wegovy is approved for adolescent obesity in US, but still in India it is not approved. So your
Sir,
views on that?
I personally believe that adolescent obesity we take up to 19 years. And you know, the obesity in the childhood, if they have type 2 diabetes also, we call it malignant diabetes, because they get much more complications. So we have pleaded with the government to get it approved. It will be coming soon, because you know, today the anti-obesity drugs, I think Anirbanda and many of you showed that slide, that are also the treatment for diabetes and hypertension. Hypertension data is not available, but diabetes data is so much available. The 2025 ADA SOP said that for the type 2 diabetes, they didn't specify obese type 2 diabetes. For type 2 diabetes, the treatment with GLP-1RA or tirzepatide holds good promise. So much so, you need not start injection lantus. I'm just telling. So that is in there. So as you rightly said, it is going to come. We are going to approve it.
So it's now a deinsulinization phase going on. What appeared was, you know, hearing you, as sir said, that obesity is now kind of transcending into an oncology kind of a treatment. I mean, all the maps coming in, all gut microbiomes and targeted therapy.
Yes.
So, you know, maybe one day beyond lifestyle counseling, we'll straight start bombarding with all these components. And maybe why not? And why not? Because you are actually hitting.
It's been a year,
I think being they call me director of this session, so I have no direction myself. So I saw this presentation which you presented. Somebody has said, Sharma, Dr. Sharma from Germany, you know, the famous, our friend, Ayush Sharma. He has said that there is no need of that's called viscero-medical conversation. You see the patient obese, need not even discuss with him. You start him on the drug, because he says drugs are so effective and the benefits are so great. You did not, as you rightly said, it is the viscerometabolic, that's called viscerometabolic communications are not necessary. You're losing time, you start drugs. Nipunda has come back. Any question on Nipun and Anirban? Yeah. Next session.
Thank you, sir.
I think great session. Big round of applause to all the three speakers. Yes, Nipunda, please. Nipunda from Sibsagar. And many of us gone to Sibsagar, you know how difficult to come from Sibsagar to this place.
Yeah, it takes almost a day. One practical experience from my side. One of my patients with diabetic for a long time and hypertensive. She sustained a renal impairment up to 2.14. serum creatinine, I started oral semaglutide. And she hasn't lost, she hasn't complained, didn't complain of any appetite loss or nausea or some sort of things. But the renal parameters improved a lot, the 2.14 coming down to 1.33, but weight was not at all.
It is known,
same.
sir.
One thing, sir. So while I revision when previously semaglutide was launched, we were told that it should be taken with a 200 ml of water, should be taken in an empty stomach. Now it has been revised to say with the sips of water not exceeding 120. So I started the same regimen to the lady, and subsequently, enough to say that she has lost 2 kg, 3 kgs within a couple of months. Is there any?
Yeah, I think.
There's a study of the area under the curve.
Yes.
That 50 to 120 ml of water and the molecule dissolving in it, the transmembrane diffusion of the snack property is held the best.
Yeah. Now she is losing her appetite also.
I think the flow trial also showed there are subsegment of patients whose kidney function improved much more than the weight loss.
That's
I
obvious,
think
sir.
this is a good observation.
Yeah.
I think these drugs are absolutely fabulous. I call it for the deadly quartet: diabetes, heart, hypertension, kidney. In the 2027 EPICON in Gurgaon, I'll be talking on that subject.
Okay.
Diabetes, hypertension, heart and kidney, the deadly octet, the deadly quartet and single answer. So I think I'm talking about the same thing we're talking, that these drugs have stood the test of time to answer this drug.
But should be taken properly.
Of course, yes. Anirbanda, any comment you want to give? So if not, dear friends, it's my duty to thank all the 10 speakers that spoke in these 4 sessions, and it's my great pleasure to invite our next speaker, next session, which will be chaired and moderated by Dr. Sushil, please come and take over. So we'll be here but to help you, but you have to conduct the session. Please come. Thank you, Debashish, and thank you, Rutul.
A big thank you to Dr. Ekedas sir for moderating the whole 3 sessions, starting from the 9 a.m. to it's almost 3 hours, and you are moderating the session. So let's start with another session, and to speak for the first topic, I'm inviting Dr. Arundhati Dasgupta from the Siliguri. She's talking on the imaging techniques to assess the body fat distribution. She's MD Medicine in the DM Endocrine and Director and Consultant Endocrinologist at Rudraksh Super Specialty Care in Siliguri. Over to you, ma'am.
Thank you so much. And thank you to the organizers for inviting me to be here. It's always a pleasure to be a part of EMOCON. So I've been assessed with the duty of talking about the imaging techniques for assessing body weight. And in this era of our better understanding of obesity, our understanding of the various ways of assessing body fat has also changed. But firstly, why does body fat imaging matter? You know a person is obese, you've seen the BMI. What do you gain to understand by, looking at where is it, how is it, does it really matter? Yes, we have understood that the clinical value of body fat is not about only what is the amount of fat, it's also about, where is it placed, is it subcutaneous, is it visceral, is it hepatic, what is the regional distribution, what are the ectopic fat depots, what is sarcopenic obesity, and now we also look at what are the changes with treatment. So you start off at a particular point, you go on to treat, and then you look at the changing parameters in terms of what is happening to the fat in the body. If you ask for what is best, now, DEXA is kind of almost the best because this is what basically kind of uses 2 X-ray photon energies to differentiate the tissues with the attenuation properties. So what do we see with DEXA? We see total fat mass, we see lean soft tissue mass, we see bone mineral content, we see regional fat distribution, and sometimes we look at the estimated visceral fat. So basically look at what is DEXA telling you. It is telling you about the fat mass, it is telling you about the lean mass, the bone mineral content, and it's telling you about the distribution in the trunk, the superior arms, the inferior arms, and the android-gynoid ratio. So the advantages with DEXA are that it is, uses very low dose radiation, short acquisition time, availability is moderately good, not as well as some of the others, good reproducibility, and you can see both the lean and the fat compartments in one study. Limitations, of course, it's expensive, it's an indirect method, it's software based, and sometimes there are issues in case of severe obesity, the table size and others, which are not actually equipped to look at people with morbid obesity. So if we basically look at a DEXA report, this is what it kind of tells us, this is what it looks like, right? So what are we trying to look at out here? When we're looking at the fat, we are not talking about the BMD out here, we're just talking about the fat. So firstly, we'll take a look at what is the total fat percentage. So the Endocrine Society of India defines obesity as a fat percentage of more than 25% in males and more than 30% in females. So you can see out here, this is a patient who, the BMI has been marked somewhere around 22, 23. So otherwise this patient would not have been marked as an obese. But if we look at the total fat percentage, it is 40%, which is way more than the cutoff, that is defined this as a male patient. So definitely this is what is known as normal weight obesity. We also look at what is known as fat mass by height square ratio, or total fat mass divided by the height. Now, so there are cutoffs based on the BMI. If you have a BMI of less than 18 or more than 25 or more than 30 or more than 35, there are cutoffs which are, which kind of tell you what is the fat mass enough or good, or is it adequate or more for this height. So you look at the cutoffs and then you decide. So here we can see the fat mass by the height square ratio is 16.3. This is a patient who has a BMI of around, say, 30. You can see it's been marked out there. So 30 and above, and for a male patient, when you look at non-Caucasians, the cutoff of anything of more than 9.2 is what tells us about obesity. So here again, another marker of obesity. Android-gynoid ratio. It's the ratio between the android region, between the last thoracic rib and the upper part of the iliac crest, and the gynoid region. And an android-gynoid ratio of more than 1 has been linked with metabolic syndrome, dyslipidemia, hypertension, etc. So again, the third point that you're looking at is the android-gynoid ratio. The fourth point is where you're looking at the muscle mass. Now here you're looking at the appendicular lean mass by the height square. So here again, we have cutoffs. This is the cutoff which has been put forward by the Asian Working Group. In men, it should be less than 7. In women, it should be less than 5.4. You can see out here that the level is 9.5. So this is a patient where you are looking at the skeletal mass. You're trying to assess whether the fat mass and the skeletal mass are in proportion, or is it more, because at times the BMI can be high if a person has a very muscular body. So in that case, the fat content might not be very high, the muscular content may be high, or in a sarcopenic obesity, it can be just the opposite, where the fat content is pretty high but the lean mass is less. So these are the parameters that you're looking at when you're trying to assess the obesity and its subtypes. And this is visceral adipose tissue. A DEXA very nicely tells us about the visceral adipose tissue. Anything less than 100, basically, in terms of the area of the VAT is normal. 100 to 130 is increased risk, and more than 130 is an increased cardiometabolic risk. You can see out here, in this patient with a BMI of 30, the VAT score is 150, which is well in the high cardiometabolic risk. And then we look at the trunk fat by the lower limb fat. So we're trying to assess whether it's central fat predominance or is it a proportionate fat. So that also helps us understand about the distribution of fat in the body. This is a picture of sarcopenic obesity. You can see out here the fat percentage is 52, whereas the appendicular lean height by square is 5.39. This is a picture of normal weight obesity where the BMI is at 22 but the total fat percentage is at 40.5%. I've just put in the picture of lipodystrophy here also to bring forth that this is not only good for looking at obesity pictures, but also when you're trying to assess about lipodystrophy, this also brings forth the picture. Next, we can also look at CT. Now, CT for fat assessment, you would wonder, but yes, it does tell us about the visceral fat, the subcutaneous fat, the intermuscular fat, the organ-associated fat, and the skeletal muscle area. So this is a picture comparing three people with a BMI of 23, 29, and 33, and you can see the distribution of fat and how it changes across, as the BMI increases, and it tells you also where the fat is placed across the different organs and how, where is it placed and what can be the, you're directly visualizing the compartments, so that tells you with precision about the visceral adipose tissue. Of course, cost is an issue, lower accessibility, need for segmentation, not a regular OPD kind of a thing that you can do a CT scan for assessing the fat, but it is required in oncology setups, in research setups, when you're talking about sarcopenic obesity assessment, and when you're looking at opportunistic composition analysis. MRI is an excellent modality for looking at the fat. It can look at, again, the total adipose tissue, the visceral and subcutaneous fat, the ectopic fat, the proton density. You can see out here a picture which has very nicely shown the subsegmentation of fats, the visceral, subcutaneous, the left anterior thigh muscle, right anterior thigh muscles, and where are the fats being placed in comparison to this. So this is what the MRI picture basically tells us. It's very powerful because it gives us an extreme anatomical detail without radiation, and particularly strong for the VAT-SAT measurement, hepatic fat quantification, intermuscular fat assessment, intramyocellular fat assessment. No radiation, excellent soft tissue contrast, but of course at the cost of higher cost, lesser availability, longer scan time, and then a lot of other factors associated with MRI. Ultrasonography can also be used in resource limited setups, but you can look at the subcutaneous fat, the abdominal fat layers, the muscle thickness, muscle architecture. But again, it is not going to give you a very good assessment about where and how much, and subsegmentation and others. It is promising point of care where other sources of assessment are not available in low resource settings. You can use ultrasonography. Now, what we are using regularly, this is a picture from my setup, a BIA. Now, typically speaking, a BIA is not really an imaging modality, but I've placed it here because a lot of us are using BIA nowadays because it tells us about the body compartments, from the electrical properties, not a radiological assessment per se, because it's not directly visualizing the tissues, but it is assessing, the various compartments, and what we are getting, is a result which is much less robust than CT or MRI, but at the same time, it is giving us an idea, and it is helping us understand about body fat percentage, fat mass, fat-free mass, total water, skeletal muscle mass, segmental lean mass, and basal metabolic rate along with visceral fat index. So these are two reports from my center that I have, just put side by side. One you can see has a BMI, I do not know if it's very clear. The BMI, one is a BMI of 21.8, the other one has a BMI of 46. Now when we compare the BIA for these two patients, let's look at the basic parameters. The BMI for the first case in a male 51-year-old is 21.8, BMI in the second case is 46. Now, but when we look at the body fat, and this is per se you would not call case 1 an obese patient, but when you're looking at the body fat percentage, normally, typically a male should have somewhere between 15 to 20%, a female should have 20 to 30%. Now the case 1 has slightly raised body fat percentage at 21.6, case 2 has huge 47.8. If you assess the total fat mass, it is 12.7 kg in the first case and 50.2 kg in the second case. Now we look at the skeletal muscle mass. Now normal range is 30 to 35, first case has 25, second case has 29. But just when you're looking at the figures, it looks normal, but when you're comparing it with the fat content, then you can see that the amount of mass, skeletal muscle mass, is pretty less in the second case as compared to the fat mass. So lean mass, again, you can see depending on the weight. Then we look at the WHR, which we know should be less than 0.9 and 0.8. Here it is 0.94 in case 1, which had a BMI of 21, remember, and 0.99. Then you look at the VFL, that is the visceral fat level. Ideally, it should be less than 10. It was 9 in case 1, but it was 15 in case 2. And visceral fat area, which should ideally be less than 100 centimeters square. It was 99 in case 1 and 203 in case 2. We looked at the body water also, which was kind of comparable and acceptable. Then the BMR, 1363 in case 1, 1555 in case 2. That was lower in case of case 1. But you also know the BI also tells you about the biological age. Now, the first person was 51-year-old. Here, the biological age came out to be 62, which was a little surprising again. Otherwise, you would have seen this patient BMI of 22, you would not have thought anything. But look at the assessments one through the BIA and where it is giving us an idea about the fat percentage and others. So basically, this person is pretty way ahead of what he should have been, while the second case is like at 28. Worse aging, but the case 1 was worst. Then you look at the segmental distribution. Trunk fat, upper limb muscle, and the first case was kind of a slight sarcopenic distribution, but the second case, it had fat increased in all the segments. The lean mass was also increased, but it was mass. So it was a generalized and visceral obesity. So this is what we saw when we compared the various, the fat distribution across the body. And so then we set our targets. So for case 1, the weight change, a little bit, the person could gain, but fat needed to come down, muscle gain needed to occur. So basically, this patient needed intervention in terms of exercise. The second case, grossly increased, just one more minute, grossly increased weight and grossly increased, we had to cut down the fat by 31.9 kg. That would require a major intervention, that is pharmacological intervention. So the future pathway, if we talk about, this is the age of AI-assisted analysis. When I asked AI what lies ahead, this is what it told me, that fat analysis, muscle fat interaction, metabolic risk assessment through the fat, AI metabolic score, adipose function, therapeutic response. You could look at a person and say, this person is going to respond to this and not to that. Weight regain prediction, continuous monitoring, just like we have CGM, we could be having something like smart wearable BIs also in future. Digital twinning, clinical decision support making with treatment engines, opportunistic imaging, and so many more other things which are probably there in the pathway. But right now, where do we stand? What do you do? For routine obesity practice, if you have access to DEXA and it is feasible, it's the most practical compromise. If you're looking at cost and others. If you want it for a research setup, precise visceral fat, ectopic fat quantification, MRI is better. For oncology preoperative assessment, opportunistic body composition, CT is better. For low resource settings, bedside ultrasound is attractive. And BIA, though not typically an imaging method, it does give us enough reasonable practical information to go ahead with our patients. So concluding thereby, so this is what we have understood till now, but we know that in the last 1 year, BIA has come up in a big way. We've understood much better. So things are improving and getting better. Our understanding is getting better day by day. But at the end of it, we need to remember that every body tells a different story. And it might be very, very must. So it is important that we as metabolic physicians, as endocrinologists, we learn to read it right. And only when we read it right will we take the correct way forward. Thank you so much.
Fantastic discussions. One question from my side would be, is there a time to do a BIA, any particular time of the day, and what are the prerequisites for doing a BIA in the clinical practice, plus the dress or the things that we wear? So should that also be taken into consideration?
Yeah, actually hydration has a strong role to play. Also factors like alcohol intake and dress, as you said, also seems to have a role. The bladder fullness, these matter. So ideally speaking, the patient should be in the fasting state, if possible, with an empty bladder, not having consumed alcohol the previous day. And when you're comparing, two parts, say you're comparing the patient again after 3 months or 6 months, ideally the conditions should be the same and the dress should also be the same. These are the ideal conditions. A patient who has heart failure, who has edema, who has other conditions where the hydration status, might be affected, these are not exact good, timings where you should be assessing the BIAs, or they can hamper the results.
So patients with heart failure and CKD, probably CKD 3,
yes,
4.
On steroids, on
Yes,
drugs
so
that affect hydration,
so
they are not the ideal candidates to be
these
assessed.
will have a confounding effect on the results that we're going to get.
That's right.
Any other questions, please?
I would say, sir, a BIA is a very, very, very practical, doable thing. It's not very expensive. It doesn't take a lot of time. It gives us a lot of answers as to, basic understanding. It might not be as good as DEXA or as CT or an MRI, but it is good enough for clinical practice and follow-up. So BIA can be integrated very well into an obesity clinic setup. Right, sir. That's a different issue.
So, with respect to 380S, 550, 970 and 770, which one do you be preferring in terms of routine clinical practice plus research approach for the BIA devices that we use?
Let me admit that I am not aware of the comparative pictures of each. So I'll have to look into this, do my homework about this.
Probably 380S is the basic one, which is around 6 to 8 lakhs. Then we have the 550, which is around 10, 12. Then 770, which is around 16 to 18. And I think the research grade, inverted commas, research grade, I think is around 25, 26 lakhs.
Right.
So these are the...
I have started with the basic model,
Okay.
but...
Okay. Okay, okay. Thank you.
Thank you so much.
Next one. Thank you. The next one, I think we would be calling upon Dr. Debashish Basu sir from Kolkata, obesity clinic, practicalities and how to incorporate into one's practice. I think a couple of questions are already answered here only. Sir, the stage is yours.
So Arundhati was, as usual, beautiful, elegant Rajdhani Express, and I'm an old hackneyed Indian Airlines Dakota, but I'll also run through as fast as I can. Now this is, she put us the flowers, and she asked to make a garland, doing all the tests, making the body trim and prim and proper. But you need a string to keep the garland held tight and maintain that. I mean, we are talking about all maintenance. So this is the practicalities I will touch upon, because we have started the obesity clinic, officially obesity clinic, almost 6 years back. I think I've got one elegant lady in the hall, Shivanti, who was also a part of this kind of a clinic. I will show you a poster where Devduhita transformed, and she came and accosted to become a model for the clinic before the COVID. So this is my small agenda. This is what the crisis is all about. We know this is doubled and almost tripled now, the incidence from 1990s when we were students, when this gentleman passed me as an MD postgraduate. And this is the money. Look at this money. If the dietitians, the educators, the doctors, you look at this number, I think this is not working. Pointed to dekho, jodi pao jaye. So this is, actually 74,000 crore is just low-hanging fruit for you and me, if their people are not waking up. So it's our responsibility to wake them up and treat them, and this money will also always be there for us. So this is what I want to tell you, that this is the increment happening every other day. These are the ORCD, the obesity-related comorbidities and diseases, and this is why you need to set up an obesity clinic. The growing demand, patients are now coming to seek help. I mean, whether it's the media, whether it's us, somehow it's happening. It is a preventable burden on healthcare, revenue opportunity for practice for all of us, fulfilling, and there's a long-term patient relationship, and then one patient gets better, he will get you plenty of them more. And all of them are getting from overweight to obese, and we must now correct the definition. I think the sir was there. We were talking about when to initiate pharmacotherapy, and I said, why do you delay treatment when you consider this to be a chronic disease? It's a chronic, relapsing, progressive, mind you, neurobehavioral, no blame shame, no willpower, it's pure biology. So this part you have to understand that, from the Delphi, I think, sir, where you are part, I think you are part of everywhere. So this was what Anubhai's publication was last year, 23 and above, and no objective sign of any functional limitation on an organ involvement, call it stage 1. So overweight and obesity now have kind of merged together from the Indian context. Let's forget about the word overweight, like pre-diabetes, talk about diabetes. BMI more than 23, then any of the following that my dear friend Arundhati told us. And then add obesity related symptoms, you are not doing what you were doing yesterday, things have changed and changed for the worse, or you have already these in yourself, they have manifested. So this is obesity. Setting up, we need these kind of instruments, and I think all of us have these instruments today. Without this, we are not actually capable to call ourselves metabolic physicians today. So this is very important. Then the next point is team structure. We must have a robust team, and one who does not have that cannot claim to be a metabolic physician. So you have to spend that money and think about in long term that you need a psychologist in your team, right? So, and then these are the administrative setup. Mind you, the first 60 minutes, first consultation is not you particularly per se, but your team as well put together. And they would actually formalize the whole game plan on the first day, breaking the ice. And then the methodology, the language, whatever they do is completely different in this context, right? And we need to have EMR for, all referral, research, etc., lab acquisition protocols. These are the weight history we talked about, activity level, eating behavior, and root causes. So you have to wear these 4 elements in the clinic. So this has to be a part of the clinic integral. This is the clinical examination that you ought to do. So as a trained clinician, first of all, you need to touch the patient, see the acanthosis nigricans, look at the buffalo hump, look at the purple stripe, and then make comments on that so that, the patient may ask you, what have you written all these? I don't follow. Then you got a scope to, patient accosts, rather than you saying, would I take this opportunity to ask you one simple question? You come with a common cold, I know, but I know, and she couldn't basically fit into the chair. She was finding it uneasy. Then you accosted. But the patient didn't agree to your proposal. She denied. And she said, age amar shordi kashita hoye jak. And this kept on happening for years. And finally, she comes with a half ref. So, so we want to prevent that, resist that from happening. This is the laboratory investigations. This is all done. We don't actually do cortisol, but all the others we do. And I think everyone should do this. We also have a sleep apnea link in the clinic, and we spend 2 hours on that. This is the stepped patient-centered approach. Step 1, lifestyle intervention. As I was saying, like oncology, you may not need anything else, just targeted therapy and Arya Sharma's comments. Then add pharmacotherapy. Asian, this was there, step 2. But today now, revised definition, 23 above. If you have a problem, don't wait for pharmacotherapy not to happen. Then the metabolic surgery. This is the dietary therapy. So, elite dietitians are here. I'll not waste my time on this. This is very important. So we need to, before you put the patient on a pharmacotherapy, ensure that the patient answers that fat phobia scale, FPS. You can Google. You are motivated, you are not. You have got those 14 questions that you need to answer to my educator. And then the educator has, from the score, derived an idea that this is the person that I can play the game with. I mean, he's a short-time runner, he's a long innings player, and I can frame and gauge my protocol accordingly. And then the entire resistance training, etc., all happens in the clinic. So this is the behavioral therapy. CBT takes a long time, but beyond that, all this is addressed, particularly the sleep part of it. Now, these are all we know. I will not dwell on it. This is the bariatric, the OSSI guidelines. So even at 25 also, you may not wait anymore if you are really at a very high risk. This is the clinic workup. First is, I am seeing the patient. If I need to refer to the cardiologist for an intervention, if I need to refer to a really sleep hygiene man, then I would. Then is the initial assessment is done. The SMART goals are all done and clearly laid down on the paper. And this is called the patient pack. Like an information label in the drug, we have a patient pack. We hand it out to patient with a file. This is the MDT formulation where the multidisciplinary team comes in. Long-term, obviously this is a long-term maintenance because this is a disease. This is not a malaria for 5 days chloroquine, right? So you need to go on. And we know obesity can only relapse if the treatment stops. Otherwise, don't blame obesity that way because you were also at fault. You did not convince the patient. ডাক্তারবাবু কতদিন খেতে হবে ওষুধটা? না 3000 টাকা, ওই 3 মাস খেলে তারপরে আমি মেয়ের বিয়ের জন্য ফিট। মেয়ের বিয়েতে আমি নাচতে পারবো তো? হ্যাঁ ঠিক আছে, মেয়ের বিয়ে থেকে নেচে এলো, নেক্সট উইদিন 3 মান্থস এত মোটা হলো কি কিছু একটা করলো, পা ভাঙলো, আরও মোটা হয়ে গেল, ওই উইথ দ্য মেয়ে কুড গিভ ইউ দ্য ফার্স্ট নাতি, she is passed away. So you don't you don't see things happening this way, but you get to see them, unfortunately. So reassess, step up, talk to them of bariatric surgery also on the first day if they fall into the criteria, because that will give them that knife fear will be something that they will think of and rather take precautions. I mean, this is the other way of looking at it. You are very supple, very subtle, very sweet in your language initially. No obesity, no fat. You are fashionably plump, madam. Fine. But then also that Damocles sword hanging on your head about a surgery and other things, because you will land up with a cabbage or maybe a CRT. You need a cardiac resynchronization therapy because your atrium is flooded with, the top of the atrium is flooded with fat, bad fat, sick fat, adiposopathy, and that's causing arrhythmia, and that's a sudden death. So you make them understand. My educators do that, not me. So that's the kind of storytelling happens, and this is the treatment phase which you and I do. Documentation. This is something that I've come here for. We never knew this or did this, particularly in Calcutta in Eastern India, which is a God forbidden chapter from the rest of the world. India also doesn't recognize Bengal. So we need to understand that the SOAP is important. Subjective, objective, assessment of the patient, and then planning the patient well. And obesity specific sections, etc. They ask, as I said, can I do this for you? Then if she agrees, assess and advise, agree, assist. So all these are there. This is the 24-hour recall that the dietitians do. We also do for other, the daily activities of living, or maybe the instrumental activities of living. This is the International Physical Activity Questionnaire. This is the Public Health Questionnaire, the Generalized Anxiety Disease Questionnaire, and the brief experiential scale. I mean, what are you experiencing? I mean, are you anxious? Do you want this? You don't want this? So we are not enforcing. We are not kind of forcing down the gullet that you have to do it. But we ensure that you are happy at the end of the day. You comply with what we are saying. And mind you, this is the most interesting subject. So my fee is at Apollo is 2,000. In the Meta Clinic, it's 1,500. No disclosures otherwise. And then when we follow up, we tame it down. But we are now forming a package, like the VLCC package, 70,000. I'll put your back to shape in 3 months. And by the next 6 months, your tick mark has gone higher up than the Nike sign. So this package pricing has to be done, so they can also have a fair idea about how things are going. Then once they're happy, the patient will come and say, well, I want to continue. I understand this is like an antihypertensive or an anti-diabetic or an statin. And these are the extra things that you need. Insurance coding, we are talking from our charity, our foundation, to the government. This is how we are now writing for our hospital patients. This is one area, the dietary counseling code for you. We are trying to improve upon this and put this on record and document BMIs serially. So that was my bit of it, and this is the challenge which we face: patient motivation and adherence. We were talking about that 1 kg weight loss and then 100 calorie coming in again that you're urged to eat. The ghrelin comes in, the leptin sleeps, and your dopamine reward function comes back. All this because your adaptive thermogenesis changes. So you need to hold it good. And time constraints in the busy clinic, I don't have, because I've got 7 girls working, non-stop. Inadequate referral pathways, all streamlined at the very beginning when you start the clinic. No stigma and bias, because you need to have that first language training. Cost of medications, of course, we have now are in a better shape in this country. And of course, relapse weight gain we know, so we do it well. So obesity is a chronic disease. Asian cutoffs, we must remember that second slide. Lifestyle therapy, GLP-1, GLP, GIP, glucagon, whatever. Know the bariatric referral criteria, because you don't waste time. But 1 month, 1 year, 2 years, you cannot do. Don't fail. Send the person. I'm focusing on bariatric because we believe in this, and invest on your team. So thank you, ladies and gentlemen. The best medicine for obesity is the one the patient will actually be able to take, and the best treatment for obesity is the holistic care that you could offer, which the patient will actually follow. Thank you. Thank you.
So
Wonderful, sir. Highly passionate talk. One question from the audience. So it was fantastic. Nothing left for imagination. Thank you, sir. If anything, we'll discuss at the end of this. I would now like to call upon the next speaker, Dr. Aritra Khan, for nutritional targets in sarcopenic obesity.
Very good afternoon to all of you. After a fantastic speaking by Dr. Basu, it was very lovely to hear always. And thank you so much EMOCON and Dr. Supratik Bhattacharya for inviting me in every year for speaking on nutritional intervention for the sarcopenic obesity. So this is a very pertinent topic nowadays because we are kept on hearing about the obesity, what about the weight, for the weight reduction, the genetic predispositions, everything. But how sarcopenia came to this picture, that is a very important part of these things. So what is sarcopenia first? The sarcopenic obesity. Because sarcopenic obesity means you have to increase your adipose tissues, your adipocyte mass, and lower level of your muscular health and lower of your muscular strength and everything. This is all about the sarcopenic obesity. So this sarcopenic obesity is coexistence. Basically your body weight will be higher, basically your central fat with the adiposity, and also your low muscle mass. Where the data says there are a lot of things nowadays we do. BMI is not only the tool, but apart from the BMI, there are the in-body, there are the DEXA, which are simultaneously important for your the muscle score and the muscle mass percentage. What we have seen that more than, if we see for the women, the 38% fat percentage is the obesity, and more in the men is more than 27% fat percentage is also the obesity. So in that cases, we have to take care about this sarcopenia part, where the sarcopenia part will be touching up if your obesity is much more higher. So in that cases, all things is simultaneously important, and the diet plays a very crucial, and diet plays a very cornerstone management mitigating all those things. Now, what is the muscle fat crosstalk? When you can see, this is a kind of a vicious cycle where we can see it predisposingly where the fat percentage is much more higher. If we consider the adiposity or the adipose tissue or the adipose site at the endocrine organ, in that cases their increasing is lot more of of your tumor necrosis factor alpha, your all the other cytokines is much more higher. Cytokines means your much more of adiposity and lower your skeletal mass. So we have to take care of these cytokines, because sometimes where we can see, if you see the muscle fat crosstalk, sometimes these cytokines are actually sometimes increase your leptin level, sometimes lowering your leptin level, and also lowering your adiponectin. This lowering adiponectin, sometimes increasing your insulin resistance, and sometimes increasing of your cardiometabolic health and problems. So in that cases, these are very much important for managing of your non-communicable disease. So if it is not properly occurred, so your non-communicable disease is much more higher. So you are landed up with the syndrome X like diabetes, cardiovascular problem, other metabolic disorders. So these cytokines are very much important, and this is all about the muscle fat crosstalk. So sarcopenic obesity, what I've told that BMI is not only the tool, but also BMI we have to take care about the segmental lean analysis and segmental fat analysis. So nowadays, where through the in-body we have to check all those things. What about the visceral fat? What about the muscle fat? What about the lean body mass? What about the fat mass? What about the extracellular, intercellular water in everything? Maybe you can see a person from the outer side. This is a patient came to my clinic. You can see the body weight is much more higher, where the BMI is 39.3. It is the morbid obesity or the grade 3 obesity, but the bone mass is 1.7. So the obesity doesn't mean your bone mass, your sarcopenia wouldn't be there. So that should be, we have to take care of. So how to take care of? To the dietetics. So we can see the thin Indian or thin fat Indian phenotype. From the outer side, you can say is a very kind of a thin, but inside there is a fat is there. So what are the major components? What is genetic predisposition, low protein intake, high refined carbohydrate diet, high saturated fat, high trans fat, lot of deep fried stuff, increasing lot of free radicals and reactive oxygen species, that can ended up with this kind of problem. Because in ancient days, what the clinical dietitian used to provide a diet chart, maybe 1200 calorie, 1500 calorie, 16, 1800 calorie in everything, and that could be maybe a standardized for any given point of a time. 2 persons are sitting, you can give the same diet chart of maybe suffering from diabetes and obesity. Now times are changing, times are evolving. Now whatever we have to say, that data should be there. So we talk about the evidence based. Maybe we can also refer any kind of evidence based peer reviewed journal, whether it's national and whether it's international. And nowadays what we are talking about, the precision nutrition. That is precision nutrition, and that is customized, therapeutic, case provide, clinical based practice diet. So that could be in higher. That is the point of discussing of these things, where there are a lot of studies of the sarcopenic obesity. We can see these studies been occurred in the Chandigarh. And also we can discuss about the exercise and community nutrition management through different type of a PubMed or index journal. So now sarcopenia will come up with a nutritional target. So what about the diet? The diet should be moderate carbohydrate, diet should be good amount of fat, there is no fat is there, and also good amount of the protein, where we can see the percentage of the ASPEN and the ASPEN guidelines. The energy 20-25 kilocalorie kg per day or high protein approach in the ASPEN guidelines. So this is all about what about the protein we can give to a person for a given point of time. But 1.2 to 1.5 gram per kg per day is the protein requirement, and for in the ICCU 2 gram per kg per day, that will be the ideal the protein percentage that we have to give. In renal patient, 0.8 to 1 gram per ideal kg body weight. If it is renal with the dialysis, then 1.2 to 1.5 to 2 gram for ideal kg body weight. Now the thing is that the protein we the clinical dietitian prescribe to our patient or to our the person who was suffering from obesity and other metabolic problem. Now what is the pacing strategy? Because protein comes stored for the muscle synthesis, so it will be a continuous supply. Maybe we can provide 80 gram of protein, so we can divide it 20, 20, 20, 20 or 25, 25 like of that. So for reducing the gluconeogenesis or neoglucogenesis, nowadays lot of dietary patterns have come up, like we are talking about the alternative fasting, talking about the time restricted feeding, intermittent fasting, keto diet, where we are taking catecholamines, cortisone and all those things. So reduce neoglucogenesis, because protein should be there. Protein would be the building block for your muscle. So that we should be catered up through our continuous supply of the protein. Lot of sources, whey sources, egg sources, lean meat sources, fish sources and soybean sources. Though soybean have phytoestrogen, and that would be again controversial or different consequences for the women. I'm not coming to this chapter right now, but apart from this, there are a lot of clinical based, publication based nutraceuticals are there, where we can talk of the different protein. What is the leucine? Leucine is basically an essential amino acid, which is actually the part of the branch chain amino acid of our valine and isoleucine, where leucine actually improve of your mammalian target of rapamycin, the mTOR pathway. This mTOR pathway actually increasing of your protein sensitivity or muscle repair or the stored muscle. So leucine supplementation 1 gram per day or food from the leucine are very, very much important for reducing sarcopenia and sarcopenic obesity. Not only that, we are also don't forget about the micronutrient, which is actually called the hidden hunger, where vitamin D, vitamin C and omega-3 fatty acid, where vitamin D, they allocate the calories through the protein to reducing the myostatin pathway and increasing the mTOR pathway, that we should give vitamin C, again scavengers of the free radicals that we can provide, acting as a potent antioxidant that we provide through our diet, because sometimes we the Indian are practicing the repeated using of the oil, lot of deep frying, increase of the trans fatty acid in our diet are very, very high. So we can use the oil but not to the deep fry, increasing lot of reactive oxygen species and the free radicals. And omega-3 fatty acids are important, PUFA, which is actually important again to increasing mTOR pathway. So food from the omega-3 fatty acid, different seeds, chia seed, flax seeds, we can provide through our diet, again by a supervision by a clinical dietitian, because there are lot of drug nutrient interaction can come up with the blood thinner drug and the omega-3 fatty acid. So we don't take this kind of thing over the counter unless and until we do discuss with a qualified clinical and critical care dietitian. And this is very important thing. So dietary patterns, we can involve the Mediterranean diet with high intake of the fruits, vegetables for lowering the inflammation, improve the muscle function and lowering the fat mass and reaching the omega-3 fatty acid, antioxidant and the polyphenols. So the fat should be there but the limited, but we shouldn't prescribe any kind of empty calorie with the sugar, aerated beverages, different carbonated beverages to a patient. And simultaneously DASH diet, dietary approach to stop hypertension, or emphasize on the fruits, vegetable, low fat dairy and the low sodium diet. So our intention to not to take up much sodium. Maybe being a clinical dietitian, we restricted the salt part, but we are not restricted the sodium part. So that is very important. On top of the outside canned food, outside preserved food are not we should take from, we are purchasing or consuming on daily basis. Once in a blue moon, that will be okay, but not on daily basis, on regular basis, this high sodium food stuffs. This could be an ideal plate where the portion size are very, very important. The diet should be good amount of the complex carbohydrate, good amount of the cereals, good amount of the vegetables, good amount of the protein and also the oils and fats. So that could be there, because dietary fiber is one of the important parameters. Nowadays we do discuss about the resistant starch and resistant maltodextrin for talking about this GLP and GIP. I need 1 more minute for. So in these cases we have to take care of these things, and your plate decides your plate. You shouldn't go for the unhealthy plate. We can go for the healthy plate where the dal, vegetables, all those things. I am eating very little. That doesn't mean you are taking low calorie, or we are taking, because you are having the 650 calories, only 5 or 6 momos, but you are having 430 calories if you are having lot of salad, vegetable, your protein part, maybe it's a vegetable protein or would be the animal protein. So the protein part could be there in your diet. Early sarcopenic risk in the young female. Not only the geriatrics, but also you can see apparently a person very lean and thin, maybe person BMI is okay, but you are not sure about the sarcopenia. So sarcopenia we can start from the early age. So that's it from my end. Thank you so much for your patient listening, and any questions so far. Thank you.
Thank you for this wonderful and lucid talk. Any questions from the audience? So one question from my side.
Yeah.
That if any patient is having the high uric acid level,
yes,
and what you will suggest in the vegetarian protein source and the non-vegetarian protein
yes
source?
So nowadays there are a lot of research been said, but previously we are taking into consideration about the purine rich food for the hyperuricemia, but nowadays what different PubMed in this journal said, apart from the purine you can try to restrict much more of the fructose. So the first, alcohol shouldn't be there, lot of fruits again shouldn't be there in the diet, but you can take a lean meat chicken, you can take the lean meat protein. or even you can take the dal and the vegetables, or like brinjal and all those things, taking into consideration with the hyperuricemia. If the patient with not the uric acidic drug, then you have to take lot of water for washing off this uric acid, but if it is not, then you can take. But the restriction part could be lot more of purine, that is spinach and all those things, and deep sea water fishes, fish roe, and the red meat preferably. Otherwise you can take everything. There is no kind of thing shimer beet chhariye shim, or you can wash the shim, or you can take the you can can't allow to have the eggplant, nothing like that.
Thank you. Thank you.
Thank you so much.
Thank you.
Thank you so much once again for inviting me over here. Thank you.
Thank you. So now moving to the different aspect of the obesity, that is a literature search for clinical questions in obesity research. And to deliver this talk, I would like to invite Dr. Satavisha Mukherjee from the Kolkata. So she is PhD in the pharmacology, the hospital and health administration, and senior research officer in the Department of Clinical and Experimental Pharmacology, School of Tropical Medicine, Kolkata. Over to you, ma'am.
Thank you, sir. So, very warm afternoon to all the delegates and my reverence to the respected chair. This topic will now focus on a very simple yet one of the most crucial step of research, that is literature search. So by literature search, we usually think of retrieving papers, but a robust literature search, I would say, has much more to it. It not only defines a clinical problem, it also distinguishes between what evidence we have and what more to generate. At this very outset, it has much more relevance to the obesity research because the entire evidence is expanding exponentially right now. So to start with, the journey of the literature search starts with a clinical uncertainty, translating that into a searchable concept, building a structured database query, refining the results iteratively, and then converting the findings into a researchable question. So the literature search starts when you in your clinical setup come across an uncertain question which you find that has not been addressed properly in the literature. So the uncertainty can arise from the variations in the treatment practices, inconsistent evidence present, insufficient outcome data. Maybe the outcome data that we have is of short-term data, we do not have any long-term data, understudied population, and very unresolved concerns. So the defined uncertainty is actually stemming from your clinical encounter and giving you a searchable question. Once you have the searchable question in mind, you need to find out what your question is. If your question is in a quantitative study, then you have various frameworks in place. The most commonly used framework is PICOTS, where we frame the question in the form of population, intervention, comparator, outcome, time, and design. So once you have the framework in place, your next thing is to find out whether it will be feasible to conduct it. So look for the feasibility, whether your idea is interesting or not, whether it's a novel idea or not. By novel, we do not mean it has never been studied yet. We mean that it has been studied but not adequately. Whether it's ethical or not, and whether your answer will be influencing the policy decisions in time to come. Once you have that checked, the next thing is to convert it into a search block. So we have PICOTS over here. We have taken up an example where the population is the adults with obesity, intervention is a digital behavioral intervention, comparator is unusual care, outcome is weight maintenance or weight loss, time is long term, and the setting is a primary care. So when we create the search block, the first thing is we create it in PIO. So population, intervention, and the outcome. So the very first block is your obesity. Block 2 becomes your digital intervention. Block 3 becomes your weight management. Now we add various synonyms to each and every block depending on whatever articles we find out. Once the synonyms are placed, we need to differentiate between two things. One, what is control vocabulary and what is keywords. Control vocabulary are database standard terminologies. Like for PubMed, we have MESH. For MBIS, we have MTree. So the work of the control vocabulary is to locate, allow you to locate the citations irrespective of the fact what the author has used in their manuscript. This is in contradiction to the free text keywords where you have to use the exact term that the author has used over there. So it's always a pro tip to combine both the control vocabulary as well as your keyword in your search query. Once you know what to build, now you have to build the query using Boolean logics and modifiers. So Boolean is actually the grammar for database searching. We have three Boolean operator and or not. Or helps to join the synonyms in each and every block, hence broaden the search, and helps to join each block and hence narrow down the search, and not helps to exclude your search. So you can also use modifiers. As modifiers we have truncators, we have phrase searchers, we have field tags. So we can use truncators where we find obesity for both OBES is constant. So we write OBES followed by an asterisk. That will be taking up all the words that comes under its variant. So we can use truncation, we can use phrase searching using quotation marks to get the exact phrase, and field tags showing you where to search it, either in title abstract in the braces or in the control vocabulary mesh in the braces. So once we know how to build the query, next term is to build the query in the PubMed, and we can also apply various optional filters in order to bring down the research. So this is an example. We can have a PubMed interface which looks like this. So we have a search tab. We gave the first block over here. The first block of ours was obesity. Once we give the obesity as the first block, the total search that we are given is 5,40,350. We add another block, that is telemedicine, which was our intervention block. Now it comes down from 5,40,000 to 1,298. We add another block, that's the outcome, so the weight loss. Now from 1,298, it further comes down to 396. When we use the further filters, it then comes down to 43. So we can sort this result by various modifiers that are given there, and we can save the result in a CSV format. We ultimately got 43 results. We want to further refine that. So for further refining that, we can use a PubMed advanced search strategy where we can give the field tags. We can either give a mesh, or we can give the Boolean operator and followed by a title and the abstract. So this now becomes a structured query which gives us a total of 5 results. So we came down from 5,40,000 to 1,298 to 396 to 43 and ultimately to 5, and this is the power of structured literature search. Mandatory step is to download the search result. So we need to scan iteratively in order to find out whether the result is too broad or too narrow. Depending on that, we can either add a concept block or delete a concept block. So you need to know what question you are aiming for, whether it's a therapy question, whether it's a prognosis question, whether it's a safety question, whether it's an implementation question. Depending on that, add the question type within your, inbuilt it within your query. That will help you out to streamline down the search. So not only the PubMed, but also the additional databases. Not only PubMed, additional databases like Embase, Cochrane Central, Web of Science, Scopus, Sinhal needs to be looked into. And not only databases, if you look only into the databases, you miss out on the ongoing trials, you miss out on the conference abstracts. So a supplementary methods researching should be done, which looks into the clinical trial registries, reference list scanning, which we say as backward chase, citation scanning, we call it as a forward chase, guideline repositories, conference proceedings, and grey literature. Once we have all the search in our vault, our next work is to fast screen them. So we review the title, abstract, study design, population intervention, outcome, and then tabulate that in an evidence matrix. The last 2 columns of the evidence matrix is most important. For every study, we need to write down what was the limitation of that study and how it is relevant to my question. Then only we can identify what is missing. We can find out which populations were underrepresented, What the outcomes to short term, comparators were poorly defined, whether there are lack of real world evidence studies are there or not, whether there has been safety uncertainties overlooked, whether there are other barriers that needs to be looked into. So we can now convert this research gap into a research question. So for this example, the digital intervention shows a short-term weight loss goals, improvement in that. But there is no data in the long-term goals, there is no data in the primary care setting, no adherence data. So we can frame our research question like in adults with obesity with primary care, does app-supported follow-up improve a 12-month weight maintenance compared with the usual follow-up? So we come to this question from the clinical uncertainty that we initiated. Last but not the least and the most important, as today it's an international journal mandate to always give the search strategy when you are submitting your manuscript. So always record the database search, when you did the search, the entire full search string, filters used, number of the results retrieved, and supplementary sources searched. This should be uploaded while we are submitting the manuscript. So the common technical errors that we come across, the questions are either too broad or too narrow. There are some obvious, we are using some obvious keywords. We ignore the mesh terms, adding too many concept blocks, overusing the filters at a very early stage, failing to search the synonyms, dependence on any single database, and lack of documentation. I would say that there is still a typical gap existing in obesity research where we can work upon. Long-term maintenance data is still scarce. There's an outcome in the elderly, rural population, and various other subsection populations are still need to be addressed. Obesity care in CKD, CVD, sleep apnea, we need more data on it. Equitability, affordability, and stigma-related barriers looked into. So I would conclude by saying that the goal is not just to retrieve the papers, but to identify the true evidence gap, refine the clinical question, and shape the next research study. Thank you. Thank you, sir.
Thank you for this wonderful and in detail lecture on the how we can review the literature for the obesity research. So it is very unique that we can do the deep study for the research. Any questions from the audience? And I would request these organizers to give us the brief about this because it is very difficult to remember all these sites and the citations. So thank you again. Thank you very much, ma'am.
Thank you, sir. Thank you all.
And I mean, over to organizers. Yeah.
Thank you, sir. Thank you, ma'am. So we are going on to the next session, that is role play. I would like to introduce Dr. Prashant Shankar, who is a consultant in medicine and diabetes at MGM Muthoot Hospital. Dr. V.K. Abhichandani, who is a consultant of diabetes and endocrine physician at Ahmedabad. And Dr. Debashish Basu, sir, once again, please. Over to you, sir.
So, very good afternoon. Am I audible? Yeah, audible. Yeah. So, very good afternoon, and it gives me. So, it gives me great pleasure to invite Dr. Sushil Patel and Dr. Vipul for the first role play. And this is a very new, exciting format we are experiencing. I mean, most of the conferences I am yet to experience this. And all three headings are very, very vital for practical utility of the current anti-obesity medicines.
I think we should sit in the audience and you guys sit on a chair so that, it looks decent. So I'll pull the chair for you.
So we are doing a role play. I am.
So who is the
I am patient.
credited doctor?
Yes, Dr. Susil is a doctor, and I am his patient.
So sit down.
Yeah.
Shall we start? So, hi, Mr. Vipul.
नमस्ते नमस्ते डॉक्टर सर नमस्ते.
How are you doing today?
सर ऐसे तो सब बढ़िया चल रहा है, लेकिन शुगर कंट्रोल नहीं आ रहा है.
अच्छा. So we had met last time maybe around 3 months back.
नहीं सर 3 मंथ तो नहीं हुए हैं. आपने बोला था 3 महीने में आने को, लेकिन हमारा तो 1 साल हो गया सर. गांव चले गए थे.
अच्छा, गांव चले गए थे तो मोस्टली इट विल बी द वेडिंग फंक्शंस एंड समथिंग लाइक दैट.
हाँ वेडिंग फंक्शन था, फिर वहाँ से हमको जाना था कहीं दर्शन करने के लिए, वहाँ चले गए. उसके बाद अभी जब वापस आए 1 महीने तक तो ठीक था, लेकिन अभी 1 महीने से थोड़ा गड़बड़ लगा तो आपका याद आ गया हमको.
अच्छा. सो आपको अभी क्या तकलीफ हो रही है?
अभी तकलीफ में ऐसे तो कुछ है नहीं, मगर आप अगर पूछ ही रहे हो तो पैरों में थोड़ी झंझनाहटी हो रही है. रात को 2-4 बार उठना पड़ता है, और बस ऐसा कुछ और नहीं है ज़्यादा.
Had you check your sugar level?
सर सही बताए तो शुगर चेक करने का इरादा था, मगर ये बाहर गए थे तो मशीन घर पे भूल गए थे. आने के बाद एक बार चेक किया तो खाने के बाद का 300 के अंदर ही रहता है सर, ज़्यादा नहीं रहता है.
मतलब 300 के अंदर आपके लिए नॉर्मल है. अच्छा, आपको और कोई कंसर्न है?
सर और कंसर्न तो ये है कि गांव में सब बता रहे थे कि अभी आपका पेट बढ़ रहा है, आप सर मोटे लग रहे हो. तो मैंने सोचा डायबिटीज़ है तो थोड़ा तो रहना चाहिए, फिर डायबिटीज़ भी कम हो जाएगा, वजन भी कम हो जाएगा, तो फिर कैसे चलेगा.
हम अपने रिकॉर्ड में जो देख रहे हैं तो आपने लास्ट विजिट से अब तक करीबन 3 किलो वेट गेन किया है.
सर गांव में रहेंगे तो वजन तो बढ़ेगा सर.
जब हमने लास्ट में विजिट किया था तब हमने बताया था कि हमें वेट लॉस करना है. सो डू यू हैव एनी कंसर्न अबाउट योर वेट ऑल्सो?
सर वेट तो कम करने का मैं सोच रहा हूँ, लेकिन डर ये लगता है कि लोग क्या कहेंगे. सूख जाते हैं तो फिर लोग टोकने लगते हैं कि थोड़ा हेल्थ का ध्यान रखिए. लेकिन आपके हिसाब से मेरा वेट क्या होना चाहिए, मेरी शुगर क्या होनी चाहिए, और मुझे आगे कैसे बढ़ना चाहिए?
देखिए, सबसे पहली बात आती है कि आपको ये कंसर्न मालूम होनी चाहिए कि वेट से क्या क्या प्रॉब्लम होती है. तो अगर आपका वज़न ज़्यादा है तो उसकी वजह से आपको डायबिटीज़ तो बढ़ सकता ही है, लेकिन उसके साथ साथ बहुत सारी एसोसिएटेड बीमारी हैं, जैसे हाइपरटेंशन है, ऑस्टियोपोरोसिस है, स्लीप एपनिया है, और बहुत सारे कॉम्प्लिकेशंस जैसे कार्डियोवास्कुलर डिजीज़, हार्ट अटैक का खतरा, स्ट्रोक का खतरा, ये सब भी बढ़ सकता है. सो वी शुड फोकस ऑन द वेट. अगर हम वेट पे फोकस करते हैं तो साथ साथ में हमारा शुगर कंट्रोल भी हो जाता है. साथ साथ में अगर आपका ब्लड प्रेशर ज़्यादा आ रहा है या तो आपको और कोई कॉम्प्लिकेशन है तो वो भी हम साथ में मैनेज कर सकते हैं इजीली. लेकिन फोकस शुड बी नॉट ओनली ऑन द शुगर लेवल. जैसे कि आपने बताया पहले कि सर शुगर बढ़ गया इसलिए हम आए हैं, बट शुड नॉट बी फोकस ओनली ऑन द नंबर ऑफ द शुगर. इट कैन बी द टोटल मैनेजमेंट. और वेट उसका बहुत ही बड़ा फैक्टर है, बिकॉज इट इंक्रीजेस ऑल द मेटाबॉलिक रिस्क फैक्टर्स.
ओके सर, तो समझ में आ गया कि शुगर को कंट्रोल करना तो ज़रूरी है ही, लेकिन शुगर के साथ अगर आपका वजन भी ज़्यादा है तो वो आपके रिस्क फैक्टर को बढ़ा देता है. तो शुगर भी कंट्रोल करिए और वजन भी कंट्रोल करिए. अच्छा. ये बात सर दिमाग में आ गई, लेकिन कैसे कम करें वजन को, ये आप समझाइए.
तो अगर आपके डाइट के बारे में बात करें तो आपका पिछले 3 महीनों में डाइट कैसा रहा होगा?
सर खाना पीना तो कंट्रोल में रहता ही नहीं. आप कुछ ऐसा इलाज बताइए कि मेरा वजन ऐसे ही कम हो जाए.
और आपका एक्सरसाइज कैसा है?
दिन भर दुकान में काम ही करते रहते सर, कभी बैठने को मिलता ही नहीं है, तो वही हमारा काम है.
तो अगर हम दुकान में काम करते रहते हैं तो दैट कैन बी अ स्टैंडिंग पोजीशन, राइट
सर.
तो स्टैंडिंग पोजीशन में अगर हम खड़े रहेंगे तो रात भर में पैर दर्द हो जाएंगे, लेकिन एक्सरसाइज जो चाहिए हमें वो तो मिलती नहीं है. ठीक है, तो हमें एक्सरसाइज पर भी काम करना पड़ेगा, थोड़ा डाइट पर भी काम करना पड़ेगा. क्या हम ये कर सकते हैं कि डाइट में थोड़ा सा पोर्शन साइज थोड़ा सा स्मॉल कर लें, थोड़ा सा हम फाइबर्स ऐड कर लें, या थोड़ा सा हमारा प्रोटीन वाला पार्ट अगर हम ऐड कर लें, तो क्या आप ये कर पाएंगे?
यस सर.
ठीक है, तो हमारे साथ हमारे डाइटिशियन भी हैं जो आपको डाइट में पूरा गाइड भी करेंगे, और साथ में हमारा थोड़ा एक्सरसाइज में अगर हम आधा घंटा अपने लिए अलग से निकाल पाएँ, जिसमें हमारा हफ्ते में 3 से 4 दिन हमारा एरोबिक एक्सरसाइज जैसे कि वॉकिंग है, साइकिलिंग है, ये सब कर लें. 2 दिन हम रेजिस्टेंस ट्रेनिंग मतलब कि थोड़ा सा मसल का एक्सरसाइज भी अगर कर लेते हैं तो वो भी हमें हेल्प करेगा. आपने बीच में पूछा मुझे कि सर व्हाट शुड बी माय वेट टारगेट, तो हमें बहुत ही एकदम से टारगेट ओरिएंटेड नहीं जाना है. लेट्स गो स्लो बाय स्लो. Let's have some initial target, maybe 3 kg of weight loss in 2 or 3 months. Then we can initiate the further. और अगर मैं आपको ये बताऊं कि अभी हमारे पास ऐसे भी काफ़ी सारी मेडिसिन्स अवेलेबल हैं जो आपको ये वेट लॉस की जर्नी में, जो आपको शुगर कंट्रोल की जर्नी में और भी अच्छे से मदद कर पाए. सो डू यू वांट टू नो अबाउट दैट आल्सो?
यस सर, लेकिन मैं ये बात सीख गया कि शुगर कंट्रोल, वेट कंट्रोल दोनों ज़रूरी है. खाली दवाई से वजन कंट्रोल नहीं करना है, रोज डाइट में भी चेंज लाना है, पोर्शन साइज कम करनी है और फाइबर भी ऐड करने हैं, प्रोटीन भी बढ़ाना है और साथ में कम से कम आधा घंटा एक्सरसाइज करनी है. अपना रूटीन जो काम है उसको एक्सरसाइज में नहीं गिनना है, अलग से कसरत करनी है. और उसके बाद आप जो बोल रहे हो दवा साथ में लेनी है.
हाँ, तो दवाई जो हम बात कर रहे हैं वो आपने जो बताया कि सर खाना तो पड़ता ही है, भूख ज़्यादा लगती है. So these medicines now it is available. It is not actually medicines. If I say that it is a natural thing what the body is producing and you have to take it. तो
अगर आप केमिकल नहीं डालेंगे ना सर?
नहीं, वही मैंने आपको बताया कि it is a natural thing what is produced in the body. So it is not a chemical. It is a natural hormone. And इसकी कोई प्रैक्टिकली कोई साइड इफेक्ट ऐसी नहीं है जो हमारे कंसर्न में आती है, जैसे कि किडनी खराब हो जाए. बल्कि उल्टा है कि उसका हमारा हार्ट पे भी अच्छा असर है, किडनी को भी प्रोटेक्ट करता है, पेरिफेरल वेसल्स को भी प्रोटेक्ट करता है, आपके लिवर को भी प्रोटेक्ट करता है, फैटी लिवर को रिवर्स करता है, साथ में वेट लॉस तो करता ही है, लेकिन अच्छी बात यह है कि आपका शुगर भी कंट्रोल करता है.
तो दवाई एक है, फायदे अनेक है.
फायदे अनेक हैं,
लेकिन लाइफस्टाइल मॉडिफिकेशन जरूरी है.
ज़रूरी इसलिए है क्योंकि अगर हम लाइफस्टाइल मॉडिफिकेशन भी करेंगे साथ में तो ये आपको और ज़्यादा अच्छे से रिजल्ट देगा और बेटर रिजल्ट आपको कम डोज में मिल जाएगा, कम टाइम में भी मिल जाएगा.
साइड इफेक्ट इसके
बहुत ही कम है. जैसे अगर हम डाइट को और एक्सरसाइज को अच्छे से फॉलो करते हैं तो साइड इफेक्ट बहुत कम देखे गए हैं, लेकिन साइड इफेक्ट भी मामूली है, जैसे नोजिया होता है, गैस है या एसिडिटी होता है. सो इसके भी ग्रेजुअल डोजेस हैं. जैसे हम कम डोज में शुरू करेंगे, 1 महीने के बाद रिव्यू करेंगे, उसके बाद उसके ऊपर का डोज, उसके ऊपर का डोज, ऐसा शुरुआत करते हैं. और अगर दवाई चालू भी करनी है तो दवाई चालू करने से पहले भी हम कुछ बेसिक रिपोर्ट्स करेंगे, जैसे आपका थायराइड फंक्शन कैसा है, आपके लीवर फंक्शंस के रिपोर्ट कैसे हैं, सोनोग्राफी में आपके क्या आ रहा है, बेसिक ब्लड रिपोर्ट्स आपके जो है शुगर का, HbA1c का, तो ये सभी रिपोर्ट्स करेंगे. उसके बाद ही हम दवाई शुरू करेंगे, तो आपको भी कोई कंसर्न नहीं रहेगी इसके बारे में.
अच्छा है सर, कोई साइड इफेक्ट नहीं है, वो भी अच्छी बात है. और ज़्यादा वेट लॉस की ज़रूरत नहीं है, वो भी अच्छी बात है. कि अगर खाली 5% वेट लॉस करते हैं तो उससे भी डिजीज मॉडिफाइंग इफेक्ट आ जाता है. आपका ब्लड प्रेशर, ब्लड शुगर, ब्लड कोलेस्ट्रॉल, उसमें भी अपने को फ़ायदा होता है. और नो मेजर साइड इफेक्ट जो हम सोच रहे हैं. लेकिन सर मैंने सुना ये दवाई गर्म बहुत पड़ती है.
गर्म पड़ेगी वो कुछ भी इसमें ऐसा नहीं है.
नहीं सर, जेब को गर्म पड़ती है.
अच्छा, जेब को गर्म पड़ेगी, अगर आपने ये सुना है तो नाउ वी हैव दैट ऑप्शंस अवेलेबल.
तो सर क्या करें, बहुत महंगी है दवा, ऐसा सुना है. तो ये खर्चा करने से ऐसा कोई फायदा होगा आगे जाके?
अगर हमने आपने बताया जैसे कि 5 to 10% ऑफ वेट लॉस अगर हम करते हैं तो हम हर एक जात की कॉम्प्लिकेशन से बच सकते हैं. अगर हम आज की तारीख में भी देखें कि अगर किडनी का कोई कॉम्प्लिकेशन हुआ, हार्ट का कोई कॉम्प्लिकेशन हुआ, तो उसका खर्चा कितना बड़ा है, और उसके सामने हमें खर्चा करने के बाद भी नॉर्मल बॉडी तो मिलता नहीं है. तो इसको आप ये समझ सकते हैं कि ये हम SIP कर रहे हैं अपने हेल्थ के पीछे. एक छोटी छोटी सी अगर SIP हम करते रहते हैं तो आपको अगर 20 साल तक, 30 साल तक एक हेल्दी बॉडी मिलता है, तो हेल्दी बॉडी के लिए तो हमारे लिए
तो चलिए सर, आप बता रहे हैं तो हम ले लेते हैं. लेकिन एक बार मेरे को असर कर गया तो मेरे तो ऐसे कई सारे दोस्त हैं जिनका मोटापा, शुगर सब ज़्यादा है, तो सबको दे सकते हैं कि दवा का कोई कॉन्ट्राइंडिकेशन भी है सर?
सबको तो नहीं दे सकते, इसके लिए आपको सबको हमारे पास लाना ही पड़ेगा.
लेकिन कैसे पेशेंट को नहीं दे सकते सर?
हाँ, तो कैसे पेशेंट्स हैं, अगर इसको जिसको समझो कि घर में किसी को थायराइड कैंसर का कॉम्प्लिकेशन है या अगर पैंक्रियाटाइटिस है, तो वो ये सभी पेशेंट में हम कॉशन रखते हैं. रेटिनोपैथी, अगर डायबिटीज़ है, रेटिनोपैथी एडवांस स्टेज में चला गया है, तो ऐसे पेशेंट में हमें नहीं लेना चाहिए. इसलिए मैंने आपको भी बताया कि आपका भी हम डायरेक्ट शुरुआत नहीं करेंगे, आपका प्रॉपर हिस्ट्री भी लेंगे, साथ में आपका छोटा मोटा रिपोर्ट्स भी करेंगे, उसके बाद ये दवाई आपके लिए भी शुरू करेंगे.
जी सर, आपका 10 मिनट ख़त्म हो गया कंसल्टिंग का. आप ज़्यादा चार्ज अभी ले लेंगे, उससे बेहतर है आप दवाई लिख दीजिए, हम दवाई जाके ले लेते हैं सर.
चलिए, थैंक यू वेरी मच एंड होप टू सी यू आफ्टर 3 months, 1 month अगेन. सो वी विल review your case after 1 month.
यस सर, ट्रांसफॉर्मेशन करके वापस मिलते हैं. थैंक यू सर.
So thank you very much for your wonderful interaction. And the takeaways for all of us are that start with permission, focus on health, not weight, and partner, don't prescribe in the first go. And the right conversation opens the door to the right care. So thank you very much.
So the next. So next we call upon stage Dr. Shubhajyoti Ghosh and Rupam Chaudhary. Their topic is a patient facing gastrointestinal issues after initiating obesity pharmacotherapy. Very common problem that all of us face, and we need to understand from them how they tackle and help us do that to us. मारपीट करबी नाকি?
Good evening, chairpersons, and to everyone. So today we have been given a role play, that's doctor-patient conversations. So my friend Rupam Chaudhary will act as a patient, and we'll be speaking on patient facing GI issues after initiating obesity pharmacotherapies.
Good afternoon. So I was suffering from obesity since long. From childhood itself, Dr. Saab, I was like very hefty. So now that I'm getting to know that obesity is the mother of everything, so I need to lose some weight. And also I'm getting married 6 months. So I need to look good in my pictures and my album. Sir, is there any way I can get some medicine for weight loss?
So initially, like before the GLP was being off patent, so we started on early state and SGLT2. So my patient will say about his experience on early state. So how you are feeling about taking the early state?
Sir, क्या दवाई दे दिया, बार-बार potty जाना पड़ता है, and then very very sticky. I have to flush multiple times, and whenever I skip the drug, तब ठीक रहता है. तो ये तो आप क्या थोड़ा अच्छा दवा दीजिए, ये फालतू दवा ये सब देते हैं, कुछ setting है क्या?
Setting तो नहीं है, but क्या है कि going potty every time, it's like drug is working. So what you can do is that you can reduce your fat intakes in the total calorie of less than 30%.
अच्छा, मतलब वो थोड़ा मटन कम खाऊं, मटन pork.
Okay. So then also we have started SGLT during the same time. So now we want to know about the patient's feedback on the SGLT2.
ये वाला दवाई किसी ने बोला मुझे, ये खाने से थोड़ा weight loss होगा 3-4 kgs. तो लेकिन डॉक्टर साहब, when I take this medicine, I feel very dry, my lips are dry, and I have to go to the loo multiple times. So what to do now?
So क्योंकि आपको हम लोग ने SGLT2 पे रखा था, it leads to dehydration. So you can increase your fluid intake to keep yourself hydrated, and also you have to maintain your hygiene. But good part is that with this drug you don't have generally GI side effects. So this drug is
that's good. आप पहले वाला जो दिया ना उससे बड़ा पेट में प्रॉब्लम. But this is like थोड़ा अभी थोड़ा सा पी सकते हैं ना?
पी सकते हो आप.
नहीं वो वाला?
पानी.
अच्छा, ठीक है. Then सर ये SGLT जो दिया वो तो ठीक है, शुगर थोड़ा कंट्रोल है. But वो 2-3 किलो weight loss हुआ. After that I'm not losing any more weight, and dehydration is okay now. So can you give me some new medicine that miracle medicine has come? You take once a week. Everybody is taking. सब लोग slim हो गए, मेरे को छोड़ के.
Okay. So I remember that first time when I've given you early state, you have got some GI problems during potty. Now if you will take early this new molecule GLP, it's a very good molecule. But वो start करने से पहले we should understand how they work and their side effects. That's important.
So कैसे weight loss कैसे करता है? ये बहुत खाना पीना बंद हो जाएगा क्या?
No, इसके पीछे reasons है कि it will slows your gastric emptying, it increase satiety, it reduce appetite via brain signaling, and it improves insulin secretions. So essentially you will eat less and you will feel full faster.
But Dr. Saab, I am a foodie. So now when you stop my pleasure, there is a pleasure hormone and pleasure point in my brain. So without Rasgulla, without fish, how can I survive? So is it like I can have some food I can have?
So this molecule again, it has, ये जो आपको दे रहे हैं, इसका आपका क्या होता है कि brain पे भी effect होता है. The GLP it affects on the hypothalamus and brain stem. जो satiety center है, इसको आप लोग depress कर देंगे, ताकि आपका भूख जो fast food या कुछ food खाने के जो मन जाता है वो कम हो जाएगा.
But I can have small portions.
हाँ.
Is it like that? Okay, okay. And one more thing, now that you have, I'm ready to take this medicine, and I have been taking this medicine now since 2 weeks. I'm feeling a lot of nausea, vomiting sensation. I'm not able to eat, and then very frequent stool, which is bothering me. So can you help me on this?
आप बता रहे हो कि आपको साइड इफेक्ट के बारे में. So if you will look into about side effect, what are the practical ways to reduce it? The practical ways to reduce it is a dietary modification. What we need to do is that we will eat small in quantity, we will have a frequent meals, then we will avoid fatty and spicy food, and we will eat slowly. And उसके बाद हमें कुछ behavioral tips भी लेना है, like you stop eating when you feel full. Avoid lying down immediately after the meal. And medication जो हम लोग आपको दे रहे हैं, we have already started at a very low dose. We will start low and we will go slowly and we will titrate it gradually.
So how long the lowest dose you have given me, how long I should carry on with that dose? What are the points factors that decides that?
So this again depends upon the percentage of weight loss you are targeting it. Suppose you are targeting about 5 to 10% of body weight loss at the initial checkup. If you achieve that target, you can continue with the same dose. If there is no side effects or like abdominal bloating or GI side effects, you can increase the dose.
I can continue with 2.5 for 2 months also if I am not comfortable, is it?
Yeah.
Okay. Thank you, doctor.
So there are few red flag signs also which we need to be considered. These are like persistent vomiting, severe abdominal pain, and the sign of dehydration. ऐसा कुछ होता है तो then we have to stop it. And after the shared decision between my patient and me, we have given him the prescriptions. This is what he is taking right now on. So now clinical algorithm, which is the clinical part, like about the GI side effect management. The step one is that you have to identify the drugs, whether it is because of GLP, orlistat or SGLT2. Then you have to assess the severity. If it is mild, then just reassure your patient. If it is moderate, then there should be dose reduction. If it is severe, temporary, there should be discontinuation. And dietary modification ke baare mein we have already discussed. And if there are the red flag signs, then we have to stop it. And these have been ADA-based recommendations and AAC clinical guideline. So these are key takeaways for our clinics. That GLP-based therapies causes GI side effect due to delayed gastric emptying, gradually central appetite regulations and altered gut motility. But with proper patient education and titration, it improves the tolerability.
Yeah, Dr. Saab, thank you for your counseling. I have last question, not only to you, we have experts sitting here. This is very popular, unpopularly popular thing that we heard about the lawsuits against GLP-1 receptor agonist, which is going on in United States, and more than 3,000 or 30,000, I think, lawsuits are there concerning the paralytic ileus or so. I would like to have some expert comment from you.
Yeah, this is a very good point. In fact, these lawsuits actually happen. I mean, it is very contextual. In America or any developed nation, you take good time to counsel the patients. The patients are not just like they come to your clinic and you sign them off with a semaglutide and they go home. So they have a shared decision-making process. The patient family, if they have, and the whole team, they usually sit down together. Now, this has been clearly explained. I mean, I'm talking about red flags. Now, you should never ignore red flags. What happened in the US, I mean, they filed the suit, but it is going in favor of us because the counselors definitely tried to normalize those symptoms by reducing the fear. They allayed the fear and the anxiety. So that was all documented. I was talking about, you were not there, about our clinic where you need to document what you're doing. That I have done this. And I've also talked to you about that if you had pancreatitis, we would be slow on that. Maybe we'll not give you this. So when this should, I mean, obviously we understand the whole purpose of GLP-1 is to slow down your gastric emptying, is to give you signal through the vagus nerve on the brain that you will not feel hungry. There's a difference between hunger and satiation. So this has been clearly, notified. So the lawsuits which happened, actually these people were over and above the GLP-1. They were trying to do things on their own. They did intermittent fasting, they did, alternate day fastings and all. So if you go and read the suit, it is not going in favor of them. It is going in favor of us, because every point they offered, they tried to call up, they looked at the adherence, they looked at asking the questions with all the dignity possible. So yes, the purpose of the molecule is to basically slow down the, the gastric, the emptying part is now slowed. So instead of 4-5 hours, they're going to 8 hours. So you can automatically, that imbibes restricted feeding. So, and over and above that, they were also taking alcohol. They have been taking alcohol and fatty food. So in this case, fatty food will, give you the layer, the GERD will happen. OSA, people have, filed with OSA, they become, from bad to worse. So I think if you counsel them well and document on your paper and give them as a perfect plan to your patient when they're taking out the file, that these have been all documented there, and they have ticked, like we do the hypoglycemia alert. আপনি বুঝেছেন তো এরকম হলে 70 নিচে 3 চামচ 54 এর নিচে হলে 6 চামচ চিনি খেতে হবে সঙ্গে সঙ্গে 15 মিনিট পরে কিন্তু will check with a glucometer. So if you have not done that and he has not ticked it, then I think we are in a mess, otherwise not.
One of the reasons is there is no dearth of tricky lawyers in US. You go to US, there are large hoardings, आपको ये होता है, approach us, we'll get you compensation. So that triggers. And very humble, something that I want to very humbly comment upon is what I have learned from your excellent role play, is that your role play beautifully highlights that GI side effects are not a barrier to therapy, they are a barrier to communication. When we set expectations early and normalize these symptoms, we convert dropouts into long-term success. So I think that is what I learned from you. Thank you.
Thank you, sir.
Thank you. If we have 1 minute, sir, what about we need to screen patient for retinopathy or not?
Yeah. Now, well, if you're looking at diabetes and obesity, of course, retinopathy is a must. If you don't do it, now you'll be into the court. But if it's an obesity, and if you have non-arteritic ischemic optic neuropathy, that has nothing to do with technically that retina we are talking about, that background retinopathy. But for the optic nerve, if you see the crowding of the optic nerve, the ratio is now there. And we have seen that it is giving you 4 times more than the other counterparts in management of diabetes and obesity. I think it is good that we screen the patients with obesity for an ophthalmologist's opinion. There's no harm. I think this is for our benefit and also for the patients, because once he has NION, then he is blind.
Thank you, sir.
Thank you, sir. Good. Last, yeah. So we have got the third speakers are Rupam Chatterjee from Kolkata and Arvind Kumar Arya from Jamshedpur. It is about counseling the patient who has achieved very pertinent, and we face this, left, right, and center. We don't have any way to answer this that way, but we all have understood that this is a molecule which should not be stopped, because this is a chronic disease you are targeting called obesity. So patient achieved desired weight and he wishes to say, Dr. Saab, enough is enough and we don't want any more. So ke Rupam Doctor na Arvind sir Doctor ke? He,
A very warm good afternoon to all of you, and at the outset we would like to extend our sincere thanks to the organizers for coming up with this topic and giving us as an opportunity. And ये बहुत अच्छा है कि मैं आज काफ़ी दिनों के बाद एक पेशेंट हूँ, मरीज हूँ, और मेरे ट्रीटिंग डॉक्टर हैं और मुझे ये अपॉर्चुनिटी मिला है कि मैं आज अपनी मन की बात सबके सामने विदाउट एनी फियर मैं डॉक्टर साहब से पूछ सकता हूँ, ठीक है? प्लीज।
So, very good afternoon. So, what brings you here today to my clinic?
वेल डॉक्टर साहब, मैं काफ़ी दिनों से आपसे मिलने की कोशिश कर रहा था, मिल नहीं पा रहा था, आपका इतना बिजी शेड्यूल चल रहा था। मेरा पूछना ये है कि आपने जो मुझे मेरा ट्रीटमेंट दिया है, मुझे दवा दिया है वेट रिड्यूस करने के लिए, तो वो तो मेरा वेट रिड्यूस हो गया एंड थैंक यू सो मच। मैं बहुत कोशिश कर रहा था, काफ़ी परेशान था, लेकिन आपके मेडिसिन से जो मेरा टारगेट था वो टारगेट मुझे मिल गया और वेट रिड्यूस हो गया। मैं ये जानना चाह रहा था कि अब तो वेट रिड्यूस हो गया, तो क्या मैं मेडिसिन बंद कर सकता हूँ या इसको और कंटिन्यू करना है, या फिर अब आगे कैसे इसके बारे में क्या करना है? आप मुझे गाइड कीजिए, मुझे आप पे पूरा भरोसा है।
थैंक यू। पहले आपकी ये दवा ठीक से लिए और आपका वेट कम हो चुका है, पर मैं आपको ये बोलना चाहता हूँ, आप दवा लिए क्यों? वेट कम करने के लिए। वेट कम करने का दवा अगर आप बंद कर देते, ये सिर्फ आपका क्वेश्चन नहीं, ये बहुत सारे पेशेंट मेरे पूछते हैं। Stopping this medication, you need to understand that you will regain your weight 5 to 10 kg within 1 year. ये मेरा बात नहीं है, ये लाखों पेशेंट के ऊपर स्टडी हुआ है आप जैसे जो ये दवा लिए थे फिर छोड़ दिए, तो वो स्टडी में दिखा गया है कि 5 से 10 kg वेट 1 साल के अंदर आप रिगेन कर लोगे, और अगर आप उससे भी ज़्यादा कंटिन्यू करोगे, मेडिसिन ले ही लोगे, तो you will regain the baseline original weight within 2 years of your stopping the medication. So will you be comfortable or happy with that?
No, not at all. I will never be happy कि हमारा वेट जो है वो फिर से रीगेन हो जाए एंड देन आफ्टर 2 years फिर ये हो जाए। आई विल नेवर बी हैप्पी। बट मैं ये जानना चाह रहा था कि क्या हम डोज कम कर सकते हैं या फिर ऑल्टरनेट डे ले सकते हैं या फिर हम उसको दूसरे चीज़ से सब्सटीट्यूट कर सकते हैं, फॉर एग्जांपल LSM और फूड और डाइट वो?
हाँ सही, वेरी इंपॉर्टेंट क्वेश्चन आप पूछे हैं। तो देखिए, ये एंटी ओबेसिटी मेडिकेशन हम सब जो मोटे वाले को नहीं देते, सो देयर आर सम इंडिकेशन। ये दवाई इतना कॉस्टली दवा इतना दिन आप खा रहे हैं, तो यदि हम कुछ क्राइटेरिया है तो आप वो क्राइटेरिया फुल किए थे, जैसे कि आपका BMI, जैसे कि बॉडी मास इंडेक्स, जो कि आपका हाइट और वेट का रेशियो वो अगर ज़्यादा हो 27-30, जिसको हम मॉर्बिड ओबेसिटी कहते हैं, वो अगर रहता है तो हम वो दवा शुरू करते हैं। जैसे उस कारण के लिए हम आपको दवा दिए थे। ये छोड़कर आपका तो बहुत कोमॉर्बिडिटीज़ भी है, आपका ऑब्स्ट्रक्टिव स्लीप एपनिया थे, आप नाथ को सोने का टाइम में आप स्नोरिंग करते थे, आपका कार्डियोवास्कुलर भी इशू है, आपका इको में प्रॉब्लम था, ECG में प्रॉब्लम था, दिखा गया था। ये कार्डियोवास्कुलर जो रिस्क जिसको रहते हैं, जिसका ये प्रॉब्लम रहते हैं, ऑब्स्ट्रक्टिव स्लीप एपनिया, ऐसे कोमॉर्बिडिटीज़ जिसको रहते हैं, तो उनको भी हम ये दवा शुरू करते हैं। और अब तो ये दवा शुरू करने के लिए अब तो 4-5 डॉक्टर ऑलरेडी दिखा चुके हैं, उसके बाद में आप हमारे पास आए। तो लाइफस्टाइल आप तो देखे थे, आप जिम भी ज्वाइन किए 2-3 साल, आप खाना भी कम किए, आप डाइटिशियन 2-3 से कंसल्ट किए हैं, तो आप तो चेंज करते ही जा रहे हैं, डाइटिशियन, जिम, पर उसके बाद भी आपको ये दवा देना पड़ा। तो अगर किसको 6 महीना और 1 साल के ज़्यादा भी लाइफस्टाइल इंटरवेंशन से वेट नहीं कम होगा, तो उनको हम ये मेडिसिन देते हैं। आपका सभी क्राइटेरिया थे वेट ये दवा देने के लिए, इसलिए हम शुरू किए। और सिर्फ खाना कम करने से या जिम करने से आपका ये सब वजन नहीं कम होगा, तो इसके लिए आई हैड स्टार्टेड यू ऑन दिस मेडिकेशन।
हाँ, वो तो ठीक है। तो आप ये कहना चाह रहे हैं कि ये जो मेडिकेशन आपने दिया, ये मेडिकेशन वेट लॉस होने के बाद भी और टारगेट वेट आने के बाद भी ये दवा कंटिन्यू करना है?
हाँ, क्योंकि देखिए इसका बहुत सारे, सिर्फ वेट नहीं, अब तो बाहर का वजन देख रहे हैं कि हम मोटा से पतले हो गए फिर हम मोटे हो जाएंगे, ये आपका कंसर्न है जो हम आपको एक्सप्लेन करना चाहते हैं, समझना चाहते हैं। पर ये अंदर के भी बहुत सारा काम ये दवा करते हैं। अगर आप ये मेडिसिन बंद कर देंगे तो आपका जो कोलेस्ट्रॉल हाई था वो फिर से घट जाएगा, आपका ब्लड प्रेशर फिर से ज़्यादा हो जाएगा टारगेट के ऊपर, आपका फास्टिंग ब्लड शुगर वो भी ज़्यादा हो जाएगा, तो बहुत सारा आपका पैरामीटर्स जो अंदर का है वो भी घट जाएगा ये दवा बंद करने से, तो यू विल नॉट बी हैप्पी विद दैट आई थिंक।
सो आप ये कहना चाह रहे हैं कि ये दवा मुझे कंटिन्यू करना चाहिए,
हाँ।
जो वेट अभी आ गया उसके बाद भी कंटिन्यू करना चाहिए, बट एट द सेम टाइम जो डाइट है उस पे भी हमें ध्यान देना पड़ेगा।
हाँ, दैट इज एसेंशियल, दैट इज
हाँ,
द कॉर्नरस्टोन।
जो-
सिर्फ दवा खाने से आपको नहीं होगा,
नहीं होगा।
डाइट एंड एक्सरसाइज आर द पिलर्स,
Yes.
दिस इज एन एडिशन नॉट अ सब्स्टिट्यूट फॉर दैट।
सो मेरे काफ़ी दोस्त लोग हैं जो मेरे फ्रेंड्स हैं, उनका कहना है कि नहीं, दवा से काफ़ी साइड इफ़ेक्ट होता है, बाद में जाके होता है, बॉडी दवा पे डिपेंडेंट हो जाता है, इसीलिए हमें दवा को थोड़े दिन के बाद रोक देना चाहिए या फिर दवा हमें अवॉइड करना चाहिए। इसके बारे में आप क्या बोलेंगे?
ना देखिए, आपका जो दोस्त बोलते हैं ये बात सही नहीं है, क्योंकि ये दवा अगर आप बंद कर देंगे, मैं जैसे बोला सिर्फ वेट नहीं बढ़ेगा आपका, आपका ब्लड प्रेशर, शुगर, कोलेस्ट्रॉल सब बढ़ जाएगा। और हम लोग ये लाखों पेशेंट के स्टडी किए हैं कि ये दवा जिंदगी भर भी लेना पड़ सकता है, मिनिमम 4 साल। सीमाग्लूटाइड जो दवा आपका चल रहा है वो 4 साल मिनिमम लेना पड़ेगा ही, नहीं तो फिर से ये सब घट जाएगा तो आपका दिक्कत हो जाएगा।
तो मैं ये जानना चाह रहा हूँ कि मान लीजिए ये दवा मैं लाइफ लॉन्ग कंटिन्यू करूँगा, सीमाग्लूटाइड, नॉट ओनली एज एंटी ओबेसिटी, इसका तो शुगर पे भी बेनिफिशियल है, तो मैं जो रेगुलर शुगर का मेडिसिन ले रहा हूँ, क्या वो मेडिसिन में डोज एडजस्ट होगा या उस मेडिसिन का डोज ऑल्टर होगा? सपोज मैं इसको कंटिन्यू कर रहा हूँ तो।
हाँ, ये कंटिन्यू आप कर रहे हैं तो ये सिर्फ तो आपका वेट नहीं कम करेगा, ये ब्लड शुगर भी कंट्रोल करेगा, ये बाकी ब्लड प्रेशर, कोलेस्ट्रॉल सबसे ही it has a good benefit on all those parameters. So definitely if you continue with this medication, adopt a good lifestyle, do daily exercise as suggested, so in that case your dose of the other drugs can be reduced, seeing the blood reports if they
डॉक्टर साहब एक बहुत ही इम्पोर्टेंट बात जो मेरे ध्यान में आ रहा है, मैं ये दवा कंटिन्यू करूँगा, मुझे सिर्फ ये बताइए कि ये दवा लेने के साथ में क्या कुछ ऐसा दवा है जो मुझे नहीं लेना है इन रेफरेंस टू ड्रग इंटरेक्शन?
ड्रग इंटरेक्शन देखिए, ये जो दवा आप लेते हैं ये तो काम करने के बाद ये लीवर में मेटाबोलाइज होगा और फॉर एक्सक्रीशन सारे जो भी दवा हम लेते हैं यूरिन से या स्टूल से निकलता है, तो एनी एंजाइम इंड्यूसर और इनहिबिटर ड्रग तो वो आपको अवॉइड करना पड़ेगा। और खाना में जैसे ग्रेप जूस, विनेगर, ये भी ऑल्टर करते हैं ड्रग मेटाबॉलिज्म को, तो ये आपको अवॉइड करना पड़ेगा। ग्रेप फ्रूट जूस।
Thank you. I think our time is up.
Yeah.
Thank you so much. Thank you.
Very, very well narrated. I mean, what comes out from these kind of interactive discussions is that we have to understand that we have to give the patient a virtual autonomy of understanding the problem in a very non-judgmental tone. No, you cannot stop it. You have to take it lifelong. Just like you are taking anti-diabetic, anti-hypertensive, you have to take it. That should not be the language. So you are absolutely right. You tried to, talk about the biology. You understand that other people are saying, "Sara जीवन लेने से तो बहुत दिक्कत हो जाएगा." So they are trying to point a finger at you, saying that you are not doing the right thing. So it is a kind of a blame. It's a modified blame that you are suffering from your friends who do not want you to take this medicine for years. But if you as a doctor could make sure that you are correcting the biology, and this is all about not a failure that you go back to the drug. Initially, the success is you have done so well. So first is empowering the patient that you have been brilliant. Now you understand that you have scored 100 upon 100. You can now score 1 out of 100. Is it a possibility, or you will score 99? So this is the choice that you leave to the patient with that grace and again the shared decision making. The patient party should be brought in here. The problem is, dubla patla, you look like a vulture, man. So now this body shaming has turned the other side. I was talking to Banshi the other day. Banshi said, "Dada, tumko kya chehra hua?" तो मैं बोला, "तू अभी हमारे को उल्टा चेहरा में गाली देगा?" बोला, मेरे को भी मिला वो गाली, तो मैं तुमको दे रहा हूँ. तो it is उल्टा गाली. So you have to understand that biology has to be explained well, and you did it so well.
Thank you so much.
So I think key message from your brilliant role play is that weight loss is a milestone. Maintenance is the true end point. So I think this is what we learned from you. Thank you very much.
Thank you.
Moving on to the next session, Advances in Diabetes Management. I would like to introduce the chairpersons, Dr. Arundhati Dasgupta, who is Director and Consultant Endocrinologist at Rudraksh Super Specialty Care, Shiliguri. Dr. Arvind Arya sir, who is Director of Bardhaman Hospital, Jamshedpur, who is a Consultant Physician and Diabetologist. And Dr. Shubhajyoti Ghosh, who is a Diabetologist at Apollo Clinic, Dibrugarh. We would also like to inform that the delegates can have their working lunch during this period. Chairperson Arvind Dasgupta, Arvind Arya, Shubhajyoti Ghosh.